questo non... Sì, sì, no, no, io non intervengo finché voi... Anche perché... Hello, good afternoon. Almost ready to start. We just wait another couple of seconds to allow more participants to join the conference room. All set? So yes, we are ready to start. So good afternoon to all of you. Thank you for joining us. Thanks to IRST, one of our European International Excellencies. Welcome here to Emilia Romagna. Welcome to this common room, common house of the German land of Hessen, the French region of Nowe Aquitaine, and the Polish region of Wielkopolska. We name them because you are familiar with working with other European partners, with other regions, other ecosystems. So please notice that you might have more partners on the top floors. So having said this, it is a real pleasure and honor to have you here, to welcome you, IRST, and to focus on the title of EU Digital Health and Cancer Care. Why is this event so pivotal and so timely today? It is so because we are at the beginning of a CLU negotiations. As you might be aware, we are starting the negotiation on the multi-annual framework program. So it is pivotal to position our regional interests, regional priorities in this phase, It is pivotal because not just the MMF is a question of financial resources, it is more than everything a question of policies, priorities. And it is so also in your sector, because the MMF will define in the next months, years to come, the future of EU for Health, the future of what is today Horizon, the future of the Competitiveness Fund, the future of cohesion, that much has to do with digital and health. Also, the MMF will deal with something very dear to you and all of you, the missions, and namely the cancer mission. And we should be all here together today to call for cancer mission to remain strong, clear in both its objective and resources. This we feel to be already a common objective to reach together. Now today we have our keynote speaker, the director of DigiSante, Antonio Parenti, in Luxembourg. And a message for the Commission is also that we are aware that there is a need to simplify and streamline EU programs, including in your area, including in the area of health, research, biotech, and resilience. Also, we recognize that there is, or there has been so far, a strong commitment of the European Commission and generally of EU institutions. You will meet tomorrow the European Parliament. There has been a strong commitment on to cancer research, and this is something that we register as very positive. However, and this is why it is so important to be here together and to start this roadmap, we believe that it is essential to work as a system to ensure that health retains a clear role in the future MMF, and possibly with a standalone funding framework for post-2027. This would be a great achievement for all our European community. So today, debate what you will develop here with working groups, with the crosstalks, is both strategic and very concrete. Strategic because you can give a clear message to the European institution about where you want to go, but very concrete because we went through at least the concept note of your interest in projects, and you all provide for very concrete solutions. So this double dimension is also very important for regional ecosystems as well as for the European institution. So let me just conclude with saying that the Emilia-Romagna region has long invested in cancer, not just research, but cancer care, with its excellences, but also supporting hubs and spokes and its integration and coordination among hospitals and territorial healthcare. So at institutional level, Emilia-Romagna is there, will be with you in the way to go. We have here representatives from the regional government. So just to a final word to thank all of you, to thank the participants, to thank the keynote speaker, Antonio. Thank you for joining us for this important initiative. Thanks to EUREGA and other European networks. EUREGA has always been a very pivotal network in the field, so thanks to you. And the final list our Professor Nicola Normanno, Scientific Director of IRST, without whom this initiative and the success of IRST would not be possible. So we wish you a very concrete, a very practical discussion. We suggest you to operate here with Chatham House rules, so that you can maybe build up something, a common position to be then share with the European institutions in a more mature way. And please note that we can be here with you supporting future projects and future initiatives together. Professor, the floor is yours.
Thanks to Lorenza. Let me thank Lorenza and all the delegation of Emilia-Romagna here for supporting us in organizing this event. Now, let me briefly introduce. How can I go to the next slide? My slide? No. Yeah, I want to just briefly introduce our institution. We are an institute that is dedicated to cancer care and research. This institute was founded in 2006 by Professor Dino Amadori, and it was recognized later as an IRCCS. So this is a specific recognition coming from the Italian Ministry of Health for centers that have a strict criteria of scientific excellence and innovation. We have a peculiar organization because we have strict collaboration with the Hospital Romagna, local health authorities, and this gives us the opportunity to really deliver optimal cancer care to all cancer patients in the Romagna region. And we do participate to Alliance Against Cancer, that is the network of the Italian National Cancer Institute. But more importantly, I mean, this institute, although relatively small, has very good European standing. We do participate to a number of European projects. We have our own liaison office in Brussels, and we are active partner, also member of a number of different associations that are aiming to promote cancer care research, and you see here a partial list. And we are happy to be here today. We'll be happy to continue to collaborate with most of you, so even after this meeting. But basically, we are here to raise our voice on the importance to have a very strong cancer program from Europe. We need a strong program for research. We need a strong program for innovation, but we need also a strong program aiming to the clinical implementation of this innovation. And I prepared a few slides. I will go very quickly through these slides just to underline why there's this need. First of all, cancer is a growing health emergency. These are the data. We do expect in the next 20 to 25 years a significant increase in incidence and mortality from cancer. And these are the figures. Now, if you look at mortality, at least in high-income countries, we do expect some slight decrease in mortality, although the incidence will slightly increase. And this is basically due to a number of factors, including the fact that now precision oncology has completely changed the paradigm of approach to cancer. We moved from the one-size-fits-all, so we were giving chemotherapy to all patients, to a new approach in which we study the molecular features of the tumor on every individual patient. We look for biomarkers for the characteristics that are associated with the response to therapy, and by matching biomarkers and drugs, we can have better efficacy, we can improve the efficacy, we reduce adverse events, and we can increase the survival of patients. This has been proven in different trials. Now, when we started a few years ago with precision oncology, we had available very few drugs for few patients. But today, over 1/3 of patients with advanced solid cancer may receive a biomarker-associated therapy. So the field is expanding rapidly, and actually the majority of new drugs that are in clinical trial are precision oncology drugs, are associated with biomarker. And now we are also moving these drugs from advanced stage to early stage. So we do expect to have even a greater impact on survival of patients. Another important point is that the effects of precision oncology go beyond cancer therapy. Now I will show you just one example, for I have a little time, but the example I'm discussing with you is about ovarian cancer. Today we test all ovarian cancer patients for BRCA mutation, because this mutation will predict sensitivity to a specific class of oncology drugs, PARP inhibitors. But a fraction of patients will have a germline BRCA mutation. These are mutations that are inherited. So by testing BRCA, we can identify the family of BRCA carriers that have higher risk to develop cancer. Now let's see what happened to ovarian cancer in the past 20 years. What we observe is a reduction in the mortality because we can provide better care to our patients. We observe an increase in the incidence. We have more women with ovarian cancer that are alive because, therapy works better. But we also observe a reduction in the incidence of ovarian cancer, less cases. The number of cases reducing over the time. Why does this happen? I mean, did the pathogenesis of the disease change? Well, the point is that by BRCA testing, we identify the family at high risk to develop cancer, and with preventive surgery, we can reduce the incidence of cancer. So this is really the power that you can get from precision oncology. This is beyond cancer therapy. Now, is this phenomenon limited to BRCA? Well, these are data, it's a busy slide, but basically the take-home message is our data suggesting that up to 15% of patients with advanced cancer may carry alterations in genes that are associated with hereditary cancer syndromes. So we could expand this also to other tumor types. We need research in this field, and we need, of course, to develop also new tools for early detection of cancer. And again, we started to use liquid biopsy just to identify the biomarkers to treat patients. But today, we have new tools based on liquid biopsy that can help also for early diagnosis of cancer. And this will be very important in particular for those tumor types in which we do not have available any screening or the effective program of screening. Now, a lot of innovation, but as a matter of fact, many patients in Europe do not have access to this innovation. We published this a few years ago. It's a map of the access to precision oncology drugs and biomarker tests across Europe. And what we found is that basically there are huge limitations, particularly in the access to more complex tests, NGS tests, in Eastern European countries as well as in Southern European countries. Now, this map was generated in 2020, 2021. We acknowledge the situation is improved in some areas, but still we have data more recent that demonstrate that there is huge disparity among patients in Europe in access to biomarker testing and therefore to precision oncology drugs. So this is an issue. And this disparity is most likely to increase in the future because we are moving from genomics to multiomics. Basically, what we have done, what we do today for precision oncology, we classify patients based on a single biomarker, most of the times a single genomic alteration. But what happens is that even with the best biomarker and the best drug, you never observe response in 100% of the patients. And even among the patients who respond to treatment, the deepness of response and the duration of response is highly variable. That's why now many labs and many centers are investing on multiomics and multimodal profiling of tumors. This is a nice research field, but this means you need infrastructure, you need the skill, and when we will move to this, the disparity between European cancer patients will increase if we do not do anything about this. And the last point that I want to touch is on the importance of data. What is happening today is that we are approving drugs for targets that are always more rare. Sometimes genomic alteration find 2%, 1%, 0.5% of cancer patients, which means that these clinical trials will lead to approval of new drugs with a few dozen patients have been treated. We are not really sure whether the drug is working and whether the target is the right target. So what is the idea is that tomorrow what we will do is maybe approve these drugs, but then use real-world data to assess whether the drug is working and maybe whether we need additional biomarkers. But to do this, we need to overcome the barriers linked to data fragmentation. We need digitalization, we need a possibility, interoperability, and we need also adequate infrastructures. So basically, the take-home message of all this is that we are in a phase of huge evolution of precision oncology and possibility to give better care to our cancer patients, but still we need a lot of research. And research that I'm not going to the detail of this because Michael will get to this, but research that must go in two directions. We need discovery, we need to continue to make innovation, to make discovery, but we need also implementation because we need really to connect the discovery phase to the change of the policy in order to make sure that all our patients might access to this innovation. And with this, I want to really thank again all of you for having accepted our invitation to be here today to discuss with us, and again also Lorenzo Badiello and the Emilia-Romagna regional delegation for hosting this event. And with this, I'm finished. So thank you very much for your attention, and I'm happy to introduce Michele Calabro, who will moderate the next session. Thanks.
Thanks a lot, Nicola. Thanks a lot, Lorenza, for the introduction. It's a pleasure to be here for me. I'm Michele Calabro, I'm the director of Euriga. That was mentioned before, one of the partners, of course, of FIRST, of Regione Emilia-Romagna, of many other people here in the room that I see. We're a network of regional and local health authorities. So it goes without saying, it's pretty clear why this event is of great importance for us and why we are particularly pleased to steer the discussion today. Indeed, just to give you a couple of very quick pointers on what's going to happen today. Indeed, we're going to have in just a few minutes an introductory talk by Antonio Parenti from DG Sante. After the introductory talk, we're going to have two panels. A first one that is going to look at a series of events, of projects that are actually running different activities in the field of cancer, looking in particular how we can translate research into policy. Then we're going to have a little bit of a coffee break, and then we're going to go into a second panel where instead we're going to look a little bit more at the future of cancer in Europe. We're going to give an example from ecosystems, still some projects, initiatives, and organizations. So we're going to finish up with a table discussion. So there's going to be a little bit of time after the panel for some question and answer. There will be colleagues possibly going around the room with microphones. So please bear with us, of course, while the colleagues will come to you. But just linking up to what was said before, this comes as a very important moment and for a very important topic. I mean, we've heard already about the importance of the discussion on the multi-annual financial framework, that of course coming from an organization that is working both at regional level and on healthcare level are of particular importance, because of course the future on the MFF will have an impact clearly on both how regional and local level can work together and at European level. But at the same time, of course, there's a lot of discussion on the future of how, let's say, the healthcare funding is going to look like within the next multi-annual financial framework. Clearly, indeed, this comes at the perfect time because it's going to give us the chance to discuss of what's happening indeed already with some examples of what's been funded at the moment. And we're also going to look a little bit at what could happen going forward and how we're going to do this. As was already anticipated by Nicola, and I will ask the colleagues from the technical department to also put up a slide with the QR code. Essentially, we have together, in particular the colleagues of FIRST, and we of course are. So let's say in today's event as well. It's a manifesto that's basically, it's kind of a starting point. So of course it's going to look at your endorsement, it's going to look at your inputs as well. But basically why we decided to include this in the discussion. Well, I guess it's important because indeed there are several risks and situations that needs to be addressed at the moment in the future of financial programs and healthcare at European level. Of course, there's always a little bit of a risk and worry that health could be deprioritized further in the next budget cycle. There are elements that are evolving constantly. Precision oncology was just a perfect example of what we need to constantly look into, how healthcare is evolving on a day-to-day basis. A lot on data. We're going to hear it from several projects today. Health data is a fundamental part of what's going to be the future of healthcare at different levels, from cancer as well. Cooperation at European level. I think we all hear from different countries, different regions, because we value the importance of cooperation and cooperation mechanism. Currently, of course, we have many ways to do so, but clearly the more we do it on a long-term basis, the more important it's going to be. And finally, of course, cancer policy can also be seen as a test for Europe's ambition in healthcare as well. You know, there has been recently the publication of the cardiovascular plan, so there's a lot to learn from cancer, from what's been happening with the cancer mission and with the cancer plan so far going forward. And you will see, you know, if you scan the QR code and look at the manifesto, that there are indeed a number of call to actions that Nicola rightfully listed before. I'm not going to go through them in details, of course, but the first important bit is, of course, to defend healthcare within the next multi-annual financial framework. We call it about ring-fencing health, of course, for cancer as well, FP10 in the MFF. So there's a plethora of programs that will be impacted, that can impact healthcare. So, of course, there has to be an important element of health there, avoiding that it's kind of too much diluted. Investment into interoperable, secure, and patient-centered digital health intervention ecosystems. A lot indeed is happening on data. We're going to hear from several colleagues about it, but clearly more can be done and more should be done going forward, also to implement policies like the European Health Data Space. Other initiatives are very important: European Comprehensive Cancer Center, initiatives like UNED CCC, but also many other cancer mission programs. You know, there's a number of activities that have been planning and working as a project, but of course should become as well concrete pillars of European cancer policy. Precision oncology, again, I think it's definitely one of the most important evolutions in the field, and of course needs to be looked as well as a strategic component. Finally, EU Cancer Mission, I think we're all here because we all value the importance of it, so I think it's an important message that needs to be indeed safeguarded as a long-term priority, and of course strengthened and build on the experiences that we had so far. Who knows, it's going to be also maybe provide inspiration for another mission. So indeed, this is not the only chance that you're going to see this QR code. Is going to be present at different moments during the day. So you're going to have more chance to dive a little bit into details, but if you can already have a look at it, but at the same time, we're going to have very interesting contributions going forward. So I'll invite you indeed to be very attentive to what speakers are going to bring to the table. And on that, I'm actually checking just if we have indeed the keynote speaker, and cannot be here in person, but we're very pleased to have a representative from the European Commission, in particular DG Sante. There you go. I see Antonio coming up online. Antonio Parenti is Director of DG Sante Public Health, Cancer and Health Security. And is going to bring a little bit of an introduction talk, a keynote talk on how European health research can shape future policies. Antonio, I think you can, we see you definitely, possibly we can hear you as well.
I hope you hear me.
We can hear you very well. Great. Pleased to have you here, of course remotely, but I'll leave the floor to you for your introduction.
Many thanks. I'm sorry I cannot be there in person. It would have been great. Hope you can hear me well. It's indeed a pleasure for me to be online and to discuss today how European research can shape future policies, particularly at the intersection of digital health and cancer care. These topics demonstrate how the European Union works, translating scientific research and innovation into tangible benefits for citizens, patients, and health systems across the member states. The European Commission approach to cancer is built on the understanding that no single policy, instrument, funding program, or technological solution can address the complexity of cancer on its own. This is why the synergy between the European Beating Cancer Plan and the EU Cancer Mission is particularly important. Together, in fact, they represent an integrated framework for aligning research, innovation, and policy across the entire cancer pathway from prevention to early detection to diagnostic, treatment, quality of life, and survivorship. Uh, the cancer mission under Horizon Europe focuses on generating new knowledge, evidence, technologies, and tools through research and innovation. The cancer plan, supported by instruments such EU for Health, focuses on turning that knowledge into concrete policy action and implementation across member states. Research informs policy, and policy creates the condition for research results, whether new treatments, diagnostics, or digital tools to be deployed and scaled up. A concrete example of this interaction is the Council recommendation on cancer screening adopted in 2022. Here, European research directly shaped the European policy. The Commission's scientific advice mechanism, coordinated by Director General RTD, provide a scientific underpinning for the proposal, assessing the latest evidence on screening effectiveness, age ranges, methods, and emerging technology. The scientific advice was reflected in the new cancer screening scheme of one of the flagship initiatives of the European Beating Cancer Plan, and as a result, the Council recommendation extends the screening recommendation beyond breast, colorectal, and cervical cancers to include lung, prostate, and gastric cancers. It is also recommended lowering the screening age for breast cancer and adopting the fecal immunochemical test as the preferred method for colorectal cancer screening. These are evidence-based policy choices that are already being taken up at national level these days. Importantly, this work is also supported by joint governance. The Cancer Mission Board, initially set up to advise the mission, also informed the development of the cancer plan. And today, a shared governance structure ensures coordination between research, health policy, and member states, helping to align priorities and maximizing its impact. Personalized cancer medicine also offers another powerful illustration on how research and policy reinforce each other. Under the cancer plan, initiatives such as the cancer diagnostic and treatment for all, including projects like PCM4U, have developed guidelines, training materials, and twinning programs that help member states in introducing personalized medicine approaches in clinical practice. This effort, in turn, fed into cancer mission research projects like PrimeRose, which are testing innovative trial design to match patients with targeted therapies based on molecular profiles. This cycle of policy enabling research and research refining policy is exactly what we are aimed to scale up. This work will be further strengthened through a new joint action on personalized cancer medicine launched in November 2025. This joint action aims to improve access to personalized cancer medicine for prevention, early detection, diagnosis, treatment, and survival, while helping member states in sharing best practices and building capacity, including in the use of digital tools, molecular diagnostics, liquid biopsy, and molecular tumor boards. Digital health and artificial intelligence are becoming essential for cancer policy. AI-supported imaging, risk stratification tools, and decision support systems are increasingly piloted with cancer mission projects. This digital transformation is linked to the European health space, which will provide a trusted framework for secure and interoperable use of health data across Europe. By enabling better use of health data for research, innovation, and policy making, the European health data space will help ensure that digital and personalized cancer care can be developed and implemented in a way that is safe, ethical, and beneficial for patients. Similarly, initiatives like the joint action ECAN Plus launched in 2025, aims to show how digital solution can support cross-border collaboration in oncology, including virtual tumor boards, telemedicine, and knowledge exchange between comprehensive cancer centers. The joint action support the implement of telemedicine activities in cancer care, addressing the needs of cancer survivors, patients undergoing active treatment, and those receiving palliative care. These tools are enablers of policy objectives such as reducing inequality in access to high-quality cancer care across Europe. To further support evidence-based decision-making, we also have established the Knowledge Center on Cancer, managed by the European Commission Joint Research Center. This flagship initiative of the Cancer Plan provides independent, scientific, and evidence-based information about cancer to inform policy development and implementation at the EU and national level. In conclusion, I would like to note that by continuing to align research excellence with policy ambition, Europe can lead in generating knowledge and turning knowledge into better cancer prevention, early diagnosis, and more personalized care for all. And this is very important for us and continues to be one of the points in which we want to deliver and more in the future. Thank you very much for your attention.
Thanks a lot, Antonio. You probably didn't hear, but of course you got your mandatory round of applause from the audience. I think it was an excellent overview of everything that is happening. Indeed, the same at this time, and indeed some of the projects that you mentioned as well. We're gonna hear from them indeed during the day. So. Thanks a lot, and maybe before we go to the first panel, maybe a question for you, Antonio, very quickly from my side. If there's something that, of course, you think could come out from this event that could be important for the work that you're doing. If you want to share maybe just a few words about that. So, we have the manifesto and everything, but of course it would be very interesting to hear what we can maybe keep in mind, all the speakers and the panelists.
Sure, many thanks. Well, clearly, there are a number of points which worth maybe recalling. First of all, it's extremely important that we keep on having a discussion on how to best implement the European Cancer Plan and the advancement on technologies, and how these translate into the reality of a regional situation like the one you are presenting here today. This is very important because in Europe we need, on the one hand, to make sure that we can catch up with the level of care and trust that exists in certain regions, but we also need to continue developing new treatment and to continue to be a force of innovation. So I'm aware of the importance of the Istituto per lo Studio dei Tumori di Amadori and the work that they do, and therefore I think it's extremely important that this is done, is brought to the attention of what is often called the Brussels bubble, but I think it's also very important that the bubble can send some messages at regional level, and this can be widespread or spread over a number of other activities. And the second point, which I think is extremely important, is to better understand what are the next frontiers, especially in terms of research and care, and what the European Union can do, the European Commission can do to make sure that this frontier continue to be a pattern and a path to be followed by all the services.
Thanks a lot, Antonio, for the additional comment. I think indeed a lot of nods and a lot of agreement here. And of course, it's an audience that definitely understands very well what you just mentioned, and it's also ready to be engaged, as we've been, I think, throughout all the different various processes and projects and so on with you. So I would say just another round of applause for Antonio Paint here from the room. Thanks, Antonio. I guess, of course, you can keep following because indeed, maybe another things that I wanted to mention, the event is also web stream, I believe, on YouTube. So, of course, also welcome. There's a very rich audience here, but there are also a number of people that are following remotely, which, of course, it's very, very important to indeed get that very European collaboration. So thanks a lot, and I think we can now go ahead indeed with the first panel of the day. So we have a very rich agenda, and the first panel indeed is going to look at translating research into policy challenges solutions, the value of European health projects. So how are we going to run this session? Essentially, we have a number of project presentations, so I'm going to call one by one all the different experts that indeed you see here in this slide. So I will indeed start in this order. Essentially, I will ask each speaker, of course, to come in. It's going to be a 5 minutes presentation. Please keep the time. And then when we all done with the round of presentations, we are going to sit around the panel. We're going to have about 40 minutes of discussion, both with a bit of questions, reaction between all the different experts, but also you're going to have time from the audience to bring in some questions if you have any. So ready then while you listen to the colleagues. And actually, I would like to invite the first speaker here to the podium. Is Jan Herman, project coordinator of FLUTE. FLUTE is a project that works on federated learning and multi-party computation techniques for prostate cancer. And Jan indeed is from INEA. I guess they gave you all the information that you need about the slides, but please, happy to have you here. You can either use this.
Okay.
You can go
Thank you.
down with the.
This is the point?
Yes, this is yours, and you can go down once the slides are gonna be up.
Okay, sorry.
Yeah, it's yours.
Okay,
And then
thanks.
if you go down, it's gonna be the next one. Just a little bit of patience because they are.
This is down, huh?
It's this one.
Ah.
There you go. Perfect. Great.
Okay. And then this is, I don't know. Okay, so thanks. So the FLUTE project, as said, is funded in the Health Call. It starts from the observation that AI is a very promising domain which has been developed over the last few years. And it is very useful in health for decision support and for research. However, recent AI models typically require a lot of data to be trained, more data than is a typical hospital. So we need a collaboration between many data owners and hospitals to fully train a single AI model. However, this brings new challenges in the sense that we need data protection, we need, this is personal data, sensitive data of patients, so we need to protect it while learning our statistical model. And so the FLUTE project is developing federated privacy-preserving machine learning techniques so that the data owners can exchange encrypted messages so that at the end of this exchange, the only thing one can extract from the exchange messages is the statistical model the data owners agreed to learn in advance. No. Okay, so in the case of FLUTE, we have a use case on prostate cancer, where we start from a number of clinical variables and from a prostate MRI image, and the task is to predict whether a biopsy is needed or not. Both an unnecessary biopsy or biopsy which is needed but not performed would of course be bad, and so it is important to minimize in both directions the error. When we think about implications of this work towards EU health policy, I think there are 3 points which are important to mention. The first point is that the technology we develop makes it more easy to satisfy all requirements from the point of view of existing new regulations such as data protection legislation and AI Act and other applicable regulations. Our system stimulates standardization and also offers a number of techniques which by design ensure that desirable properties such as privacy, security, reliability are all satisfied. A second important thing is that the research we do helps to better understand how policies, regulations on the one hand, and technical solutions on the other hand can be aligned. If we look, for example, at the GDPR, we see that it contains numerous times, I think some 115 times, the word appropriate, where the legislator has wisely decided to not hard-code in the law a certain level of technological performance to be achieved, because this technology is evolving very rapidly. That would not be a good solution, but still saying in the law only that the solution should be appropriate means that, okay, we need, when we deploy something to the market, we need to decide what is sufficiently appropriate to be acceptable. And for industry, this is important since, of course, one would like certainty before one deploys an expensive product to the market. Same in the AI Act, there high-risk AI is subject to conditions, but the AI Act itself doesn't specify in detail all conditions, and these are things which need to be further elaborated, and an improved understanding of what level of protection corresponds to what practical protection of data in practice would help to better define thresholds which new technology needs to meet in order to be acceptable. Thirdly, we believe that this technology, when being deployed more broadly, will help to speed up the process from research to testing solutions towards uptake in the market, which is often a very expensive and long trajectory nowadays, by automating more things, by design, including guarantees so that ethical procedures, etc., could become shorter. This will hopefully stimulate the speed with which medical innovations can be taken up. So in conclusion, FLUT tries to develop a bit of new technology which supports potential new implications on EU health policy. Thanks for your attention.
Thanks a lot, Jan. Please do sit down back to your seat. So we'll, as you know, the setup doesn't allow us to have you all here at the same time, but we'll call you back, I promise, to have the discussion. And while we wait for a little bit of refreshment of our second speakers, I'm happy to introduce you to Mark van den Bulke, project coordinator of Ciensano, and you're very busy. I see that you're going to bring a couple of projects to the table. ECAN Plus, enhancing digital capacity for cancer center in the European Union to improve prevention and care, but also you're going to touch on the JAPCM, Joint Action Personalized Cancer Medicine. So Mark, the floor is yours.
Yeah. So thank you very much for the invitation to be able to present some of the projects we're running here. And I have only 5 minutes, but luckily Already part of the project was presented by the other, I think Nicola and also Antonio. You talked about personalized cancer medicine, so I can skip that a little bit, but I will give it at the end. So the first one is ECAN, and that was the first time we had digital into the, let's say, the policy support actions of cancer. And it came from the observation that during COVID, there was a need for patients to be followed up, and they used telemedicine and telemonitoring, especially teleconsultation also. And from then, the Commission opened the possibility to have a joint action, and they asked us to lead it. We took it, although it's not really our specialty. There were 16 countries participating, and then we got representatives, and it was a very diverse group of representatives. People, normally you have public health people, you have people from hospitals, now we have people from computational, from economics. So we thought in the beginning this is going to be difficult, but it worked out very well. And actually what we did is from the beginning we said, on the suggestion of DG Santé, make use cases. And the use cases were indeed very useful at identifying where the gaps are. And that's after 2 years. We only had 2 years. We tried to set up 2 small clinical trials. It worked. We could do some things. But in the end, we came with a roadmap. And the roadmap is on 6 major domains. I'm not going to go into detail, but that allowed us to convince the Commission to have a follow-up joint action, ECAN Plus. And now you see we have already 23 countries, where we were only 40 partners in the beginning. Now we are 86. And we are going to, instead of, let's say, be a little bit more flu, it's now on cancer centers. So it's on hospitals directed. We're going to continue to have tools, telemedicine and teleconsultation, but we're also going to explore the European health data space. You hear, we have to share data, so this is going to be one of the issues also. In all of the joint actions, you will see also training of health professionals and patients and the population is very important. So in the next slide, you see the organization. Again, we're going to use pilots and use cases. And the pilots in this case, they will be on partially cancer prevention linked to an app that the Commission has already been produced in the earlier phases on, let's say, promoting the European Code Against Cancer. Then we have one on molecular tumor boards. I think, Nicola, you mentioned it already, very important in introducing precision medicine. And the other one is on survivorship, where also we will explore one of the apps that the Commission has been developed. Now, this is ECAN Plus. Now, if we go to the Joint Action Personalized Cancer Medicine, we have also a number of pilots. We have more pilots here, and we actually see that these pilots, it was not our aim because we are leading also this joint action, but the partners came up with a pilot on risk-informed cancer prevention, digitally driven. There is one on molecular tumor boards. Now you will see the one in ECAN is more on the digital aspects and the infrastructural. Here it will be really on the use in the clinic. And we will link it to another initiative, the EUNET CCC, it was already mentioned, the Network of Comprehensive Cancer Centers, because it's there that these molecular tumor boards will be really used. And then here also we have another digital application on survivorship. So you see there is mirror between the different joint actions, and we are now going to push that into getting synergies towards really ensuring this. And now I'm coming back to what I heard already both by Antonio and by Nicola. We want to increase the access. And I think, Nicola, it would be nice that your map that you made in 22, we actualize it to 25. We can do that with a group. Then share data and best practices and build this knowledge both with the health professionals, with the citizens, with the patients. And this is, you see, we are now 29 countries, 145 partners, so it's a huge joint action. UNED-CC is a bit bigger, overlapping with us, but there's a huge potential of doing things together. And then this is the structure. We are in 3 arms, and we are continuous. We have an arm on precision prevention, we have an arm on precision medicine, and an arm on precision survivorship. And the pilots run over that, and we are going to make sure that there is a continuum. And that's what we start tomorrow. The kickoff, the official kickoff was in November, but now we have the launch tomorrow and the day after tomorrow. And we're going to start discussing amongst how we're going to realize this continuation. And these are the synergies where you see that ECAN Plus is in there. There's also the Joint Action Permit, but there are also the RTD initiatives on the partnerships that are going to join. And there's a number of other projects that we are linking to. But the challenge in the coming 4 or 5 years will be to try to integrate all the outcomes that are being delivered by these projects into something tangible that can be useful in local organizations. I think that was for me.
Thanks a lot, Mark. And we'll welcome you back and good luck also with the launch tomorrow, I guess, of the new activity. A pleasure also to see that it can continue. We had it several times also discussed within the working group on Council of Euriga. So great to see that things continue. And talking about things that they continue and are running now, I'm happy to have the third speakers here with us. Of course, we're talking a lot about digital and innovation in cancer care, but goes without saying, everything needs to happen with the work of healthcare professionals, for which skills are, of course, essential. And on this, I would like to welcome on stage Federica Magre, Executive Director of the European Health Management Association and coordinator of the Be Well project, that's going to talk about that. So slides are going to appear in just a second.
Yes, thank you. Wonderful. So good afternoon, everyone. Thank you so much for the kind invitation. I am delighted to speak about the Be Well project. As Michele has anticipated, this project is not specifically focusing on cancer, is actually focusing on the upskilling and reskilling of the health and care workforce, specifically on digital and green skills. And the reason why we think that this is particularly fitting today's meeting is because we do treat skills and the workforce as a precondition for anything that has to do with health policy, and any reforms that want to be implemented, they have to start from the concept of providing the health and care workers with the skills. And so one of the things that the Be Well project focuses on, as I mentioned, is digital skills. And here you can see some information around the digital skills gap. So 80% of health and care professionals report insufficient training on digital skills. And between 30 and 70% of professionals report that they have a perceived skills mismatch. And of course, this goes hand in hand with the concept that technologies are so fast-paced that it's very difficult to keep up in general. So as soon as we potentially train for a skills or a specific technology, another has already appeared on the market. And so this is the reason why, well, one of the reasons why the Be Well project was developed. The vision is to develop a skills strategy for the upskilling and reskilling of the health and care workforce on the green and digital skills, also to prepare them for the dual digital and twin transitions. And the way the Be Well project does this is through training. So we have developed a significant number of training. We have developed skills intelligence. We have established a large-scale partnership where we can bring together different organizations that indeed have at the heart the upskilling and reskilling of healthcare workers. And this is just to give you a sense of some of the trainings that we have developed throughout the project that has entered the last 6 months of activities. So we have developed a significant number of courses on digital skills. We have been able to train over 500 people. This, of course, goes hand in hand with a bunch of other trainings on different topics. And I think that what I wanted to mention is some of the results that and some of the lessons learned that we were able to gain from the analysis of the data that we got from the training. So first of all, we see that there is a little bit of a disparity in terms of gender of people that took the training, yet in any case around 60 to 40% in favor of female users. We have employment status with around 60% of people employed that took the courses and 40% of students. And then we can also see here that the occupation, so who are the users of the courses, and I think it's worth mentioning that doctors are a fairly low number compared to other occupations or other profiles. And so all of these to mention a few things that we have learned and that we are going to implement when it comes to developing the skill strategy, and things that we need to consider when developing health policies that involve health and care workers. Clearly, there is a workforce crisis, and so this means that health and care professionals do not have time. So this means that when it comes to engaging with training, students tend to have more time. That's their profession, to study, to engage with training. So as a consequence, when developing training, when developing skill strategy, we really need to take into consideration the limited time availability of professionals. The other thing that we need to consider is how important are networks and local contacts to encourage participation in training. We had, in terms of country participation, very strong results when we had a strong local presence. And this goes hand in hand with shifting to a culture that encourages lifelong learning and having champions within organizations. If we can have someone that sort of paves the way, then we know that there will be a stronger uptake when it comes to the taking of training courses. And then, of course, we also want to secure support within organizations. So clearly, if an external provider comes in and say, we have developed this suite of courses, well, nobody will take them. We need to have management support when it comes to developing trainings, and especially when we want the health and care workers to engage with the trainings that we have developed. So these are the lessons learned that we have developed, and all of these will feed into the skill strategy. So the skill strategy is not yet developed. It has been developed in a first version, which is currently now under consultation. We are keeping it open for just another couple of weeks. And the idea is, in fact, to get feedback from health and care workers so that when this skill strategy will be ready, this will be implementable at local, regional, and European level, so that we can provide some concrete, actionable opportunity for organizations, local and regional authorities to better train our health and care workers. And I know it's another QR code, and I don't want to confuse you with the QR code of the event. However, if you do have a spare 10 minutes, we would very much appreciate if you could fill in the short questionnaire. It takes really 10 minutes, and it will enable us to indeed feed your feedback into the skill strategy. It's available in multiple languages. So I'll leave it here for just another second because I see some people are scanning, and this is important. I know Michele is knows because he's also a member of the project. So we would very much appreciate these and your participation in these. Otherwise, you can find the same QR code on the bewellproject.eu website. So with these, I thank you very much for your time and attention, and I hand over to Michele.
Thanks a lot, Federica. I think we'll make sure that, of course, everything that is shared is also shared in follow-up, I suppose, to the meeting. So that's important. And, you know, Bewell, it's a particularly important project as we partner with it, and also leading the work of the partnership on the health ecosystem. And it's bringing stakeholders together to discuss exactly what Federica mentioned. And I want to also mention the fact that that both IRST and Regione Emilia-Romagna have been like a fundamental part of the discussion since the very beginning of the partnership. So happy to go to the next speaker now, and welcome on stage Oriana Nanni. You're playing at home because you're also from IRST, and Oriana is going to bring as the Impact AML approach, Pan-European Framework for Evidence-Based Cancer Care. There you go, you have it.
Thank you. Good afternoon, everyone. Today I will present our project focusing on value of its potential to translate result into clinical practice. As background, acute leukemia, myeloid leukemia, when become a relapse or it is refractory to the first line of therapy, it become a high impact disease with no standard of care, but we have multiple therapeutic options, but none of them are effective and the prognosis is very bad. Moreover, we have no head-to-head comparison between the option available across the member status of Europe, so we don't know what is the best treatment for this disease. There is no interest for the commercial pharma for these comparative studies, and the need urgent for innovative therapeutics strategies. Our study has several key objectives. The first one is to establish an European registry for all patients with this disease. The second is to develop standardized biobanking and procedures, in particular with on the residual disease assessment. It is a very crucial aspect. But first of all, is to conduct a randomized clinical pragmatic trial on this setting of patients and to integrate key perspective for all stakeholders. Our consortium include a lot of institutions. It is a very big consortium. And at IRC, I am the operative project coordination. But while Professor Martinelli from University of Bologna is the ideator of this project and the scientific coordinator. As regards the pragmatic trial, the call of Mission Cancer is specific for pragmatic trial. As you know, pragmatic trials are randomized clinical trial with robust scientific and methodologic requirement, but very close to real world. So the results could be transferred and used in clinical practice rapidly and in a very short time. So it is very important for our future patients. So this pragmatic trial compare two different approaches, two different strategies in this setting of patients according to a real world. So the inclusion criteria are very broad, the population is unselected, the disease assessment is very close to clinical practice, there are no extra routine assessment, so we can reflect the effectiveness of these strategies in a context of real world. But it is not only a pragmatic clinical trial. Our study include a registry for all unselected patients with this disease in a platform registry when diagnosis, assessment, treatment, and survival data are collected. Some of these patients can participate to the randomized trial, but some of them could be included in specific studies on new drugs or on specific orphan settings, such as patients, pediatric patients, or very old patients. Moreover, we have to try to standardize some procedures, all within the network of our study. As far today, more than 30 clinical sites are recruiting in clinical practice, in a clinical randomized pragmatic trial. More than 40 clinical studies are ongoing across 7 countries in Europe, and up to date, more than 160 patients are included. In the context to address a critical scientific question that only academia could answer. So the results of our study could be easily included in guideline across the member states of Euro, and it is very important to transfer the results into clinical practice. As AML is a rare disease, a strong and a very wide network is necessary to better understand this disease, including clinicians, translational research, regulatory experts, because in Europe it is not so easy to go with clinical studies across across the countries. And it is very important for us because it is very easy to transfer our results to clinical practice, including patients association and stakeholder as regional authority and so on. Thank you.
Thanks a lot, Arianna. Call you back in a minute to continue the discussion. Next projects, I'm happy to have Silvia Tognetti, project coordinator at the Center for Genomic Regulation. Silvia is going to bring the experience from the INCAS project on fundamental discovery to societal relevance, learning to capture impact through, indeed, the project that Silvia is going to bring to the table. Wait a second, and you have everything that you need.
Okay. Thank you very much, and I think I'm going to bring a little bit of a different perspective to the audience. Sorry. Okay. As we are here discussing the role of fundamental research in the health ecosystem, so the European health and cancer policies rely on scientific evidence, much of which is actually produced in fundamental research centers quite a while before it can be translated into clinical or into policy. So given that the impact pathways are long, non-linear, and often difficult to track, it is the challenge that we have as a fundamental research center is to actually being able to track the contributions that are produced within our research ecosystem in quite early, let's say, connecting with the enablers within the health ecosystem, tracing the impact over time, and then finally visibilizing, ensuring visibility for policy translation. So who are we? The CRG is a fundamental research center, a biomedical one, that although we don't have a disease-specific focus, we work very extensively on, we have sustained research lines in cancer, genome studies. We apply artificial intelligence to different health studies, and we collaborate with clinical research groups in a very extensive ways. In the last few years, we have supported more than 200 research groups, and half of our scientific production was in collaboration with the clinical groups. So for us, it is quite important to being able to visibilize sorry, this is strange, the impact of our research in a way that is actually translated into clinical practice and finally translates into policy. So because being a fundamental research center, we are quite far apart from the actual implementation of the adoption of what is the subject of studies. In our center, we have always paid quite a bit of attention to responsible research practices. As enablers of impact. So we have had projects that are actually several European projects on different aspects of research quality, including openness, reproducibility, integrity, equity, and sustainability to drive long-term scientific and societal progress. In 2023, we have had an establishment of a specific area within our institute that is dedicated to the evaluation of scientific outputs and outcomes, the increase of the scientific qualities, and the generation of evidence that can inform policy. And we have started a pilot project in 2025 that is basically piloting a framework to ensure that the societal value of our fundamental research is better recognized and assessed. So in our center, we have quite several impact stories. We can see some here. Several of those are related to rare diseases where our research could actually influence the diagnosis and even the precision targeted personalized therapy that was given to the patients. And also we have several stories of infrastructures that are built with the technologies where we are experts that are actually platforms for European use. We have patents and clinical technology co-developed with clinical partners, and we have also several spin-offs that are working with clinical partners. 6 of these only established in the last 6 years. So while these are positive stories, we have a challenge that is to actually visibilize all the stories that we actually don't know about. So there is a difficulty to get our researchers to being able to identify the actual impacts over the long term. And also, as you know, there is a translational gap, which is a lack of funding between the first funding and support between the first phases of research and actually clinical translation. So in order to tackle this, we have planned a project that we are now piloting at the institutional level that is mainly about raising awareness on the importance of early thoughts on impact across our research community, so to empower them to recognize and track impact from the onset of their project. So they will have the chance to think more in depth about what they are going to do at project planning in order to better enable impact generation. And also we are piloting a workflow for the definition of impact narratives at the institutional level with the establishment of an institutional body, the Impact Task Force, for decision-making processes and the definition of new indicators. So finally, what we are trying to do here is to make sure that impact considerations are embedded in project planning, especially for early stage researchers, so that they know that the impact considerations are something that need to be taken into account during project planning in order to establish meaningful collaboration. So the second pillar would be to connect early with relevant stakeholders within the health ecosystem. Many of us are here probably in this audience to support collaboration and translation across sectors. And finally, make these pathways from the fundamental research science to the impact generation more visible to a more effectively informed health policy. Thank you.
Thanks a lot indeed. We touched something a little bit different from the other project on awareness, and I'm sure that it's going to come up later. And indeed, I think it's a plan of the events like these to connect the stakeholders that are needed for projects like what we just heard. Last but not least from this session, I'm happy to welcome on stage Giorgio Cangioli, technical lead of HL7 Europe, who's going to bring even another experience, in this case from the Phoenix project and on European Common Cancer Model. Giorgio?
Thank you.
Please.
Good afternoon. Really a pleasure to be here. Let's see if the slide has arrived. Okay, so what I would like to talk here is about not a funded project. I would like to talk about the standardization activity and stakeholder engagement in that. So just to introduce who we are, maybe you know, but HL7 is an international standard organization that owns most of the largely used standard like V2, CDA, or FHIR. And HL7 Europe is the representative of HL7 in Europe, and we are in charge of developing a standard for Europe, trying to engage using the community that are based on the existing European affiliate. Just to mention what we are working as HL7 in Europe right now. The main activity, as you can imagine, is about the health data space. We are working on a series of FHIR-based standards for the different categories. The good news that all those standards have been adopted by the XTHR joint action and are also in the cross-border specification for MyHealth@You, those that the new services that are FHIR-based. What we hope is that they will be also taken account by the implementing act for the health data space. But we are not only working on standard, we also look to the communities. This is really important for us, and to engage. Thank you, and to engage a stakeholder. One initiative is the Hospital on Fire. The other one, that is what I would like to talk about with you today, is Phoenix and the Common Cancer Model. Why Phoenix? I don't need to explain why cancer is important and how much it's critical to assure that to offer a unified approach for the primary and the secondary use of data. And what we try to do with Phoenix is to introduce a new way to develop standard. We try to use a concept that is largely used in US, that is called accelerator. That means that the standard, we use the open and consensus-based process offered by the standard organization, but having the stakeholder that are the main driver for that. So we try to take together, in that case, some National Cancer Institute, French and Dutch, and other research institute, and to give them the governance and that initiative in order to support the adoption, to drive the consistency, to make something that could be sustainable also long term. The first standardization project of that Phoenix initiative is a common cancer data model. The idea is to develop a minimal, extensible, non-exhaustive data model that is agnostic to the type of cancer usable across different use cases. Maybe some of this work can recall you the International Patient Summary approach. Trying to leverage on existing projects like Flute or IDEA4RC and other, but taking into account what is substantially actually available in the EHR system, not trying to invent something that can be only applied in 20 years' time. So I try to see what is actually there. So where we are now, we have the chance to engage some clinicians that help us to agree about the concept, define what is usually called a conceptual model. We are there. There is a static model. The nice thing that these people try to explain how this information should evolve over time during the cancer journey, from the start, from the diagnosis to the death of the patient. And the next step will be that of identifying more in detail the attribute, and then to have a FHIR representation of this data. So, as HL7 Europe, we try to offer a neutral European platform in order to facilitate the engagement of people. I'm insisting in participating because I don't believe that standard can be made in a closed room, and we are happy that the project that I mentioned, the standard I mentioned, saw the involvement of more than 200 people. This is a huge number. Obviously, this helped the fact that it is the regulation about the health data space. People are interested in being engaged. We hope that that we can offer a better engagement of stakeholders as active driver of the standardization effort. This is what we are trying to do through the Phoenix initiative. The thought that I mentioned before is only the initial founding member, but the idea is to open and to grow and to help and to allow other organizations to join the initiative. And we are trying to promote that Common Concern Model initiative to help the transfer of data from the primary care to the secondary use. And the nice news is that we are working at the European level to try to achieve the health data space objective, but we are already in touch with the US, M-Code, maybe some of you heard about that, M-Code initiative of the Codex Accelerator, to try to work in the next future in a universal, the global common cancer data model that take into account the two requirements from Europe and US. Thank you.
Okay, you can stay here, yes, because now just give a couple of seconds that we're going to have the setup of the chairs, and I will ask all the speakers from this panel to be back here with us in the panel. So Jan, Mark, Federica, Oriana, and of course Silvia. What we're going to do, I'm going to run basically a very quick question, and indeed we are a bit behind in terms of time, but we started also a little bit later, so we're going to try to have about half an hour discussion, so we can also have some time for questions from the audience. So if you have something already, start kind of preparing question in a little bit, and indeed everyone has their own microphone, but I mean, what I wanted to do first, it's a little bit of a comment from everyone here around the table, as we've heard a very, very diverse, but at the same time equally important in the way that they interact with the ecosystem of cancer and health, examples of projects, example of what's happening, of course, at European level. And maybe I will start here with Jan with a little bit of a question, also looking at the theme of this panel in terms of policy challenges, solutions. So for you, your project, of course, it focuses a lot on artificial intelligence. And in your mind, and from what you've seen in the projects, what should change at EU policy level, maybe in terms of governance, implementation, for solution and for projects like Fluke to move forward? So what could be your wish also for the next steps? Yeah.
Nowadays, okay. So in recent years, we have seen several projects developing all kinds of new technologies, both medical innovations and more AI, statistics and algorithms-related contributions. And it becomes important to see how we can all integrate this in our healthcare system in a consistent and easy way. And there, I think one of the important challenges is to regulate, but not to over-regulate. So there is regulation needed. There is a need to ensure that the regulation is not so heavy that it doesn't allow movement to a better, more trustworthy and more agile technology. So seeing how this can be done flexibly and inspired by new strategies invented from research seems an important objective for the next few years.
Thanks a lot indeed. Regulation, not over-regulation, integration. A couple of things that that I get from what you mentioned, and maybe some other colleagues would like to also bring on that. And I'll now go to Mark. I mean, indeed, you brought forward two projects actually, and one it's also been like a continuation of an existing one. But like in terms of the EU policy environment and funding situations that we're now having in terms of discussion, what do you see as something that could ensure that what you're doing maybe is going to even carry forward and have that even closer implementation? You talk about use cases as well, so really how to transfer also to implementation.
Yeah, thank you. I think to continue on the regulatory side, because this is going to be a very important element, I think the option that we will get on installing regulatory sandboxes is something that we really have to pursue. And there is already a project ongoing and trying to define that a little bit for health. So that is definitely something that we can work on. And then the other thing is we should maybe better define once what exactly we need. That might be a good start, because there are a lot of options and opportunities at the European level to do jointly things, and I think especially on the pre-commercial procurements and procurements of public, the procurement of public innovation. These are things that I think that should get known better to people, but there are things that we can already do. We don't need many more things. The other thing is to take stock of what has been done in the European Beatings Cancer Plan and the mission on cancer, because I think there is a lot of output that we are not aware of, and I'm constantly learning. So that is another thing that I think that could already help us a lot.
It's an excellent point, and I think it's one of the elements as well of the manifesto, like to consolidate, not necessarily to invent the wheel every time. And we've seen it, of course, working a lot with regional authorities, and I think that's also why we brought this forward. A lot stays in implementation, and not necessarily you need a new project or something to do that, or like going back to the drawing board. So the very important point also on things that could be better known. PCP as well, it's being one of them. And Federica, maybe I'm coming to you now, because of course on BeWell side, let's say we're working more on skills rather than the technology, and looking ahead, of course it's not a cancer focused project, but how do you see better integration of upskilling efforts on digital, but I mean green as well, are the elements as a condition for system transformation?
It's number A2. Okay, perfect. Thank you. Wonderful. So indeed, the BeWell project is not a technology project, but I think that the reason why it fits is because it really looks at the enabling condition for then technology to work. And if we think about better integration, I would advocate in a sense for a few shifts. So the first shift is that skills needs to be considered infrastructure. And so in a sense, what happens is that, again, there is a technology or there is a reform, and we expect that just because something has been implemented or it's on the ground, then the workforce will adapt suddenly, magically. There is no, let's say, thought around how do we actually make sure that the workforce is able to use a new technology or can absorb and adapt to a reform. The other thing is that the training is fragmented, and so we should definitely switch from what is a one-off training to a systemic approach to training, which goes back to first point. So we develop a reform, we create a new technology, we put it in place, and we systematically do training. So training that is funded, that is recognized, and therefore I go to my third point, which is really protecting the investment in training. So making sure that training is embedded, is recognized, is accredited, because right now we focus on the goodwill of the individual. And I am a doctor, a nurse, an allied health professional, so whatever is my role, and I do want to do good. So I do want to train, I do want to improve. I but that should be at system level. So there should be some real management support around it. And so I think that all of these, especially because what we have discovered around BeWell is, of course, there are skills gaps, but the skills gaps are not just clinical or technical. These are transversal skills as well. So we're looking at sustainability skills, we're looking at communication skills, we're looking at collaboration skills, team working skills. So all of these should really be integrated at system level. And so we should do it in a systematic way through strategies, not one-off training, and not relying on the goodwill of the individual.
Absolutely, and of course, I mean, I particularly like the point on starting to shift to look at skills as an infrastructural element, because I think it's something that probably all the projects that we've heard now and we're going to hear later need to have in terms of update and deliver an impact. And on impact, maybe Oriana, coming to you, as of course you have a strong focus on evidence-based, and of course you're also working with ERSTAT at regional and local level. Essentially, it's why we also here. And how do you see, you know, the work that you're doing really moving towards uptake by regions and other stakeholders across Europe? Is there anything as well that the other colleagues mentioned that particularly reflects?
Thank you for this question, because there is a wide heterogeneity in drug availability across the countries. And it is a common situation for many diseases, not only for our disease in our studies. And usually we have not head-to-head comparison within a clinical trial. So the guidelines could not be considered the best option for each situation. And it is not an interest for the pharma. It is a need that only academia could answer. So the European community is asked to give evidence, to translate this data, this information, this evidence into clinical practice. So the community, the European community could the only sponsor for this type of studies. And it is very important and pragmatic trial link this aspect. Its results could transfer to be included in a guideline. So it is very rapidly to translate in clinical practice. And it is important to share and to standardize all the aspects on clinical research, because despite an European regulation, there is also very critical aspect, very barriers to conduct studies across member status in Europe. So it is very useful for us, to the community, to share and to standardize the process. It is very important.
Indeed, and it goes back to the point of like looking at what's happening already, because I mean, I guess in healthcare, as in any other topics, in cancer, as in any other parts of health, everyone's kind of facing similar challenges, and somebody maybe found a solution that might be indeed applicable, maybe not exactly, but like kind of with some adaptation. So indeed, that's a good point with the EU, of course, as an accelerator of that. I think projects like everyone is kind of looking at that. And staying on impact, maybe, you know, with coming to Silvia and on capturing impact as well. What changes do you see? I mean, how does your project and maybe the discussion that you had have been fitting with the current kind of EU outlook in terms of healthcare, and what do you think it might change in terms of EU research, you know, framework to maybe to better integrate, you know, what you're working on in the longer term? You know, if, there you go.
Well, our conversations institutionally and with our networks and alliances have been very much focused on the role of the researchers into the definition of impact, especially fundamental researchers, and how this figure has changed over the last decades, and how sometimes researchers are struggling to find their actual place. So they're not only required to do excellent science, but to also be always on top of the different connection and networking ecosystems, to be looking for fundings more and more. It is increasingly difficult to do so. So I think one of the important conversations was this a little redefinition of the figure of the scientist, the biomedical scientist at present. And while senior researchers have been, trained over the years to actually being able to see impact when they conceptualize their project, our focus is specifically into training the junior early stage researchers into this consideration. So to embed the impact considerations in their project planning, to look for collaborators, to look for stakeholders, to think about what is the potential outcome, not because we expect them to produce this impact earlier than what is the natural course of the research, but because the simple thought of what can happen enables them to make this actually go into the right direction. So we think that this is quite important, and our researchers have been quite welcoming of this actual the potential of thinking about this from an early stage, because they feel that they are more connected to what they're actually doing. Fundamental research is sometimes difficult to explain, difficult to, even to your families, even if there is a potential clinical impact at the end of the road, your contribution to it sometimes feels very far away. So being able to really understand what you can do to make your research valuable for the impact that you propose, it is quite important for them. So it's also uplifting, I think, for the research community, and is definitely something that is relevant for upskilling as well, no? For thinking differently about their projects.
And I think it's an excellent point, because I think another element of what we're also discussing today is how, to reshape, future research in cancer, but that applies everywhere. And I think you rightfully mentioned this tension maybe from the constant need of looking for, funding to continue research, to continue innovation, as sometimes, at least personal opinion, when you look at try to define impact, you're almost scared indeed things like looking back at what's happening already and trying to build on existing experiences. It's kind of perceived as not that impactful, as like looking at something from scratch. So the work that you're doing, like bringing it at like the forefront, let's say, with discussion, it's very important. And I'll be happy also to hear if other colleagues have something on these. And last but not least, I'm coming to Giorgio. Of course, your focus is a lot on interoperability and common models that are critical to everything that is happening. But of course, it's been, it's a journey in a way. And it takes, I think, elements of what we heard, skills and engagement with stakeholders and impact. So what in your opinion, we should prioritize at European level to kind of advance it further and make, work like the one that you're doing more as a common rule and rather not an exception, but like examples?
I mean, that if I'm thinking how to scale up interoperability in Europe, obviously you cannot just refer to a single policy level. Obviously you need to have a coordinated and governed strategy for that. Taking into account different aspects, obviously promoting standardization, regulation, incentive also. Obviously, I have my standard development organization hat. Obviously, I would like to see the Europe that incentivate the development of open and participative standards. But I recognize that regulation is important to really drive the adoption. And incentives are essential if you want to promote exercise, to have harmonization of the market and so on. So let's just to summarize, obviously when I say a coordinated strategy, an ideal workflow might be that you should have a sort of regulatory direction. This is what you like to obtain. Then to have incentive in order to start exercising, learning, starting developing standard. then to promote the consolidation of standard, and then at that point in time to have the regulation that take into account all these aspects of the previous step and can be actually used and adopted. Because one thing that I felt, sorry to say that, in some regulation, that sometimes it happened, the stakeholder consultation happened after the fact. You collect feedback and you say, sorry, it's too late, we have no time to take into account all your input. I would like to have regulatory more co-created, and this might be easier to do if we take into account all these steps before. Thank you.
Thanks a lot, and maybe we'll come back indeed with a final comment. But like excellent point to close. Indeed, consultation comes last at some point, and I think we should all indeed have that in mind. And I mean, personally, I've been working for patient organizations now, of course, with regional authorities. Sometimes it's paradoxical, but I kind of see like let's say the implementation side and the receivers of innovation having that like too late consultation moment at the same time, and say, oh, well, this is not working. Actually, this is too expensive. This is not responsive for patients, for professionals. So I think that's an effort to make. Let me pause there because we have also, of course, time for questions from the audience, and I see colleagues there ready to take yours if you have any. So. I'm not sure if we have any question at this stage. You were all very clear, I suppose. But one thing that maybe in the meantime that people have a thought about, like we talk a little bit about this need of in a way co-designing and bringing forward the discussion on impact. This is something that you struggle with or you looked at in your respective projects, and at the same time, is there one thing that you would like to see in the next, I don't know, financial framework or let's say implementation of the plan that could facilitate that? No, that's a difficult question, I know, but you have an audience that can answer, I would say, and listen to it.
I can comment on this. I already mentioned it in my presentation. Definitely, it would be to ensure that there is funding for bridging the research from fundamental to translational. It is quite challenging to find sufficient funding, especially for technology, innovative technologies. They are expensive, and it is very hard to find fundings for these stages where you have a proof of principle, but you don't have enough evidence to actually convince investors that your technology is potentially working. So if we want this to actually make a difference for the health ecosystem and for patients and the society in general, it's important. So at European level, this should be tackled.
More focus on that, indeed. Anyone else wants to bring on that? Maybe Giorgio, and I see Federica.
I mean, that's fine. I'm happy to comment. The part about funding is a very sensitive point for NGOs in general, because of course, as probably many of you know, the operating grant that were so fundamental for our work were cut. So clearly NGOs, many of us are in significant financial trouble to indeed ensure the continuity of our operations. But these aside, I think that, of course, I support the concept of we need to have funding. The thing about impact, and we had this conversation, Michele, in reference to a different project, is it's always hard to quantify impact, and it's always hard to enter in the mind of the evaluator to then understand what is impact for them. We had a very similar discussion. So what is the baseline? So what is the baseline for impact? What is the baseline for innovation? Because to use a very basic example, where there are no computers, introducing a computer is innovation. yet. It's just a computer. So yes, indeed, it's not an innovation per se, but it is innovation in a process where that computer didn't exist. So again, I think we need probably to understand what is the baseline to understand impact. Maybe a little bit more guidance on that would be helpful.
And I think indeed, we have translating research into policy, but at the same time, there's policy that is driving research that then is feeding back into implementation and policy again. So maybe, that loop, it's also a little bit more to complete. Anyone else wants to bring some experiences, I know, from Flute or the other projects?
Yes, so I think I agree that with the others that funding is of course important to be able to do innovation. On the other hand, I think it is very good to have initiatives such as today, but maybe they are not sufficient to kind of ensure that between the many initiatives we have in Europe, there is sufficient alignment and collaboration. And okay, you can do standardization, you can do events, but somehow at the point where projects are selected, they can promise to collaborate with other projects, but they don't know which other projects will exist at the point of funding. So it is hard to have as integral part of a project a collaboration with other projects, and this sometimes makes projects do things which partially overlap or are not fully aligned, and maybe not only at a high level thinking of how everything can organize, but also to have more concrete low-level collaborations between the several initiatives, not only projects, but also standardization efforts, existing programs, could probably be something to pay attention to.
Very good. Just looking at the audience, Ninka, question there, and then we go to a couple of closing remarks. But actually, just to comment quickly, very good point, because a lot we are in kind of a tunnel vision when we get into our projects, and indeed we don't know, we have to collaborate. I think the cluster system that we've seen, at least in our experience in some of our mission cancer projects that we have, it's a good step in that way, because it kind of integrates that. But of course, the challenges that you mentioned, Jana, are very much there. But please, and introduce yourself.
Yes. Nienke Schutte, working at Scienzano. Thank you, Michele, for moderating this great panel, and thank you to the panelists for the great presentations. I had a question for the first speaker, Jan, about the project that you presented to us. So in the project, you are pioneering, actually. I think you mentioned it in federated learning. And I was wondering, we heard in the panel a lot of barriers that were mentioned, so skills that were missing sometimes to get things done, regulation, the last speaker was really arguing that regulation can be an incentive. But what were the barriers for the federated learning that you performed in your project? Of course, I assume that you included the front runners in your area of expertise. However, I can imagine that onboarding others in this endeavor might pose some problems. Could you comment on the most common barriers for these people to join this endeavor? Thank you.
Yeah, thanks for the question. So our project's trying for one of the first times to do real federated learning in a privacy-preserving way between multiple hospitals, and also a data owner, a company. We started from what exists before, which means that most people involved are used to kind of the classic way to perform medical studies. And so we need to go through the classic ethical committee approval, to do all the classical procedures, which not always apply very well to the new technology we develop. So you will see, and if you want to get to demonstrate that you comply with GDPR, they will ask you what data do you share with others. But we tell, okay, we don't share data because we only exchange encrypted messages. So a lot of questions are not applicable. And that means that somehow we need, that's why I argue, okay, we need to ensure that this regulation, which is very necessary because we want to avoid that dangerous techniques are applied without sufficient care. We need to ensure that this regulation is sufficiently flexible to incorporate these kind of new technologies. Next to the matter of trying to find a consensus and training and our complete consortium, I think it is also important to we develop technically the solutions, the privacy-preserving federated learning techniques, but then integrating everything and making the different disciplines work together requires a bit of time. Not only to understand each other, to learn each other language, but also because, okay, there is a need for standardization. All data owners need to use the data in the same form. There is a need to realize what kind of statistical problems there are when you apply studies on a large scale, cross-border in multiple countries. So many new questions and challenges arise, which during the project, we try to address in some way, but now that the project is finished, we hope to somehow find a second opportunity to do the same exercise again, but in a much better way with the lessons we learned over the past few years.
Thanks a lot. Oriana, Mark, I don't know if you wanted to add something to the discussion. Maybe you met some of the same challenges or you want to do the same things.
There are barriers for Jan, but also for clinical trial across Europe. So it's very important to share with health authority, with national health authority involved in the study, because there is a very, very wide heterogeneity for this, and for academia that can answer only for needs that it is not important for pharmaceutical companies. There are many neglected diseases. It is very important to share the regulation, to share all the activity for the clinical research. It's very important for us.
And Mark, something similar that, I mean, in your double experience, but surely many more, you would like to comment on?
Well, I think we have the advantage in Europe now that we are more than 15 years already working together, that it became a community, and I think now is where we, having these regulations and having these hurdles where you have to agree and understand what you do, you can much more rapidly come to common understanding and having these networks in place where you introduce, and the first thing we will have to do probably in, for example, EUNET CCC is agree how we're going to share data and make clear controls, clear contracts, everything in place so that when you start something new, you don't have to each time go through this discussion, because it's there that you lose lots of time. We had a project Can Heal in preparation of our joint action. There was an exchange, and Rogero, it was Patrizio who led the trial. We had to make 62 contracts between 7 partners to do exchange. That takes an enormous amount of time, so we have to clarify. We clarified it, and now it goes. So this is something that, and this is where the strength of these networks will become very, very much apparent.
Very good point to finish this panel. Indeed, we have an experience, and we also have challenges. We've seen things that don't work. We've seen things that work. We have a new MFF in front of us that can probably change the way that we do research at the European level. I think there's a lot of things that can be taken. I'm standing here between the coffee break and the panel, so I would like, first of all, to ask like a big round of applause to all the speakers for this first discussion. We now have, we're happy to welcome you to a coffee break there. I think it's going to be just outside of the room for about 30 minutes, a little bit more than that. So I'll ask you to be back sharp, let's say between 4:35 and 4:40, so we can start very sharp the second panel and the discussion. Thanks a lot. Perfect. So as people are coming back slowly but surely from the coffee break, you've been very disciplined, so thanks. So we can start in time. Probably you know already there's going to be a networking aperitif later, so you were happy to take a step in that direction as well. But before that, we have a really nice panel discussion. As you know, we heard a lot about examples of existing cancer research so far, about the impact that they can have on policy, about the learnings that they can share between themselves, actually, with all of you, and towards also the planning of the new financial framework and beyond. And now, in the second panel, we're going to be looking at a slightly different thing, but yet with some great examples from across Europe, as that's the overall plan for the meeting. And in particular, we're looking at the future of cancer research in Europe. From before we look at research to policy, now we're looking a little bit more from evidence to ecosystems to actions with indeed an ecosystem approach and ambition. So we're going to have 7 this time speakers. So it's very packed agenda, and but one of them, the first one, Tiit Albrecht, is the president of the European Public Health Association organization. It's actually unfortunately not able to be here with us, but he kindly sent a video message that will be displayed as the beginning of this session. So before we one by one go to the different speakers in person, I will just ask the colleagues from the technical side to bring it in with his presentation. So let's go with it.
Good afternoon and welcome to all, and many thanks to the organizers for the kind invitation and for allowing me to present some of the views of the European Public Health Association on this very interesting and challenging topic. So the future of cancer research in Europe, starting from evidence to action, different ecosystem approaches and ambitions. I believe that there are some key messages for scientific development in public health. The first one is definitely to insist on scientific evidence as the base for health interventions overall, but also specifically to public health interventions and policy measures. We have many reactions today to some of the traditional scientific findings where we are challenged by people who don't start their assumptions from a clear scientific base, but they instead resort to prejudice, the so-called, very often abused framing of common sense and similar. Scientific evidence has to be the base. Also, when you object something that is the current finding, it has to be provided with clear evidence and scientific background, because otherwise this only projects personal views. There is a need to develop adequate monitoring mechanisms for all policy measures and interventions, also at the population level. You cannot blindly introduce interventions and then later regret that the outcomes have not been as they were expected. There has to be a pre-phase, preparatory phase, and then also the introduction. This does not mean only interventions that relate to healthy, but also the population of patients. There needs to be a structured process which is scientifically based, and it has to be designed in advance in order to evaluate all proposals that feed into decision-making actions with impact at the population level. Finally, in this part, I would like to stress the importance of synergies and concerted actions across different stakeholders and players. By players, I mean also the civil society, the non-governmental organizations who can often help steer the process of introduction of certain interventions, not only when they were the result of their own initiatives, but often also when they simply participated in such. We have to innovate approaches and methodologies. The pandemic of COVID-19 taught us many useful lessons. Presenting scientific evidence in a dry, bland way will not lead to the acceptance of measures. We need much more. We need a framing of evidence and following up on the additional knowledge, which is at least equally important. We have to be aware that we have to develop our communication skills. We should not come forward as prohibitive, limiting, and overall restrictive to the population. We have to explain the measures, and we also explain why certain scientific findings point to certain measures in practice. Of course, I would advocate and vouch for the need for a significantly bigger and more extensive support to outcomes research. We need to I shouldn't say that. We should stress the importance of outcomes research, which is at least as important for the final assessment and also the population perception of interventions that we have built on the scientific evidence. I will give finally an example about the possible solutions for improvements in lung cancer screening. Each of these elements that I have listed here should also be supported by further scientific research and exploration, which should assess the usefulness of different interventions and different approaches. We should work on a comprehensive and intelligent system to provide populations at risk instruments in order to assess their potential risk of developing lung cancer. When speaking about lung cancer screening, we have developed the idea that, of course, we will approach populations at high risk, but they have to be made aware that they are at high risk, and the instruments that assess their risk are quite simple and quite intuitive. And I think we have to use the different digital and AI tools to support people who would like to actually find out about the risk and also act accordingly. The next step is empowering primary care providers to actively work with persons at risk by raising awareness, inviting to smoking quittal programs, as well as screening programs. We have to support, of course, providers who are very limited in time in such ways that these assessments are done as they go forward, and that we also evaluate the assessment of modifications that we have achieved through various programs. And finally, we have to develop research in order to support the assessment of risk for those persons who have been or were in the past exposed to important cancer carcinogens, which means other carcinogens beyond tobacco smoking, it's environmental pollution, it's contamination, it's working place exposure. intelligent systems, digital support, and AI will be extremely important in providing challenges and opportunities in research, how to support these assessments. I would like to thank you very much for your attention and for the invitation and the possibility to present some of my reflections. Thank you very much.
I think 90% of the people in this room know Tit personally, so I'm sure they will make him know that of course, as usual, the public health perspective was very much welcome in today's discussion. But as of course, we cannot really have a follow-up with Tit, I would like to go and invite here the second speaker for this panel. Iñaki Gutierrez Ibalutea. He's the Health Research Innovation and Evaluation Director of the Minister of Health, the Basque Government, and of course also pleasure to have him as Vice Chair of Euriga. Iñaki, the floor is yours and the slides will be charged in a second.
Yeah, thank you very much for inviting me to be here, and I will be perhaps less global than Tit and much more concrete on things that we are doing at the regional level. I'm used to say that the Basque region, it is the fourth Baltic country because we are similar size. So Lithuania, Latvia and Estonia, they have 2.2 million inhabitants more or less, and we are 2.2. So we can say that we are a country, and that's why we are called the Basque country. So I'm going to talk about a little bit about ecosystems as catalyzers of translational research into healthcare and how we have pointed out. And I was talking also with someone from the Commission that is in care of cancer policies, and I was saying that the comprehensive cancer centers structure, it has been an opportunity for many reasons. What we did, and when we arrived into the government, we were in need to provide for the citizens the Basque Comprehensive Cancer Plan, and for us was an opportunity first of all to work together with the society on the one side, and also to pull the European Union policies into practice. And then it arrived three things. So it was. So it was on the one side, the comprehensive cancer centers, that it was part of the things. Also, we had the possibility of going for the comprehensive cancer infrastructures, and we were one of the selected regions in terms of developing infrastructures and having experts with us. And when we started with a participatory model. In this case, we created a strategic committee with 19 people in the Basque region, a workshop with 60 people, some advisory boards, but was more important, working groups with the clinicians and also with the patients. In total, we have also validation groups with patient groups with 7 people, with associations group, 8 associations, and also with the academia. So it was a full comprehensive cancer plan. Furthermore, we finished with 7 priority areas, 35 objectives, 142 actions, 81 indicators, and more than, as I said before, more than 200 participants. What it was important to us, it is how European Union policies could be implemented in reality. And that was a clear challenge. By the way, it is not just in Basque and Spanish. You can obtain the cancer plan in English. These are the priority areas for action, at least for us. On the one side, it is people, the core of the Basque Comprehensive Cancer Plan, but it was the healthcare model. So which was the healthcare model that we wanted to put in place as a country. And in this sense, the healthcare model was based on, we are an integrative country. So Tit Albrecht was talking about the importance of primary care. We have embedded in the system. So we have divided in integrated care regions. The second one was, promotion and prevention. Obviously, it was early detection. We have one of the highest rates of participation in colorectal cancer, breast cancer, and cervical cancer in the world, so similar to Finland. Also comprehensive care. But one of the things that was, and it was also aligned with the policies of the European Union, being focused on health outcomes, registration, reporting, and surveillance systems. That it was one of the challenges. And finally, research and innovation. These are some of the things that we have going to put in place in the next years. But I wanted to talk about especially about the last one. That is, work towards obtaining accreditation as a comprehensive cancer center. When we started, one of the challenges was that it was the Commission that came to us saying, you need to be if you wanted to provide high quality services, you need to be certified as a comprehensive cancer center. Immediately, we have 5 university hospitals in the Basque region, and they said, each of those said, we are going to be the one. And we said, no, you are going to go together. And that is the difference. So it was from the very beginning saying that it is independently on where you live, you are going to receive the same thing. And we said, if we are 2.2 million inhabitants, we need just a single comprehensive cancer center and not 5. And any single citizen needs to receive the same services. Apart from that, and I'm going also to put some kind of dynamics, it is to develop corporate dashboards to measure prevalence, incidence, and health outcomes in oncological processes differentiated by sex to allow evaluation and comparability in terms of clinical effectiveness. We started with an strategy that was related to being focused not on services and processes. Probably you have heard for many, I would say, specialists that they are saying that is lack of professionals in Europe. From my point of view, is lack of management in many countries in Europe. And the focus it is mainly on structure and services and not on outcomes in reality. If we go to how it has evolved in the case of cancer, the results and the outcomes that we had in the last 20 years, as we have seen before from the keynote speaker, it is the outcomes has improved a lot. And also to be focused in another thing that I wanted to put in place. We have created a single and accessible centralized clinical trials platform. So there is a single window for the whole region in which any kind of promoter that wants to make any kind of clinical trial needs to knock that window, and then we put in place how the trials are going to be developed. And also with detailed information on active trials. Why we could do that? Because we have the same information system and we have a single electronic health record for the whole region. Just to finalize, this is how it was organized also from the research, development, and innovation. So we were talking about ecosystems, so it's not just the provision of healthcare, but also research and development. For that, we have 4 research institutes. Each of those, they are located and they are covering the 3 provinces in the Basque Country. On the one side, Álava, that is the capital city is Vitoria, Biscay, that is the capital city is Bilbao, and Gipuzkoa, that is the capital city is San Sebastian on Donostia. And in each of those, they are providing the whole services to the different hospitals that are based. As we can see in the next slide, we have divided the territory in sub-regions, by which in each of the sub-regions, they have at least 1 hospital, and they are interacted with a tertiary hospital. And also they are embedded with primary care. So this is the coverage of the Via Biscay. So they are covering 5 hospitals, 5 tertiary hospitals plus long-term care hospitals like Gorliz and Santa Marina. Same in the case of the Via Gipuzkoa, that they are covering 6 hospitals plus the mental health network. And in the case of Álava, that is smaller, they are covering with one of the tertiary hospitals and also the mental health network. Apart from that, we were considering as an ecosystem that is not sufficient. And we are collaborating also with academia, with the 4 universities that are based in the country, with the other private healthcare providers that they are also providing information to us, and with a cluster of companies in terms of also sharing the knowledge that we have in terms of advancing in many senses. And within that, we have included 2 units of advanced therapies for that. So it's working closer together with companies, with the Basque Research and Technology Alliance, that is belonging to the Ministry of Industry, and also with the research centers that are belonging to the Ministry of Education. And that is all. So what we have learned, it is in principle that we need to work as an ecosystem on the one side. We need to think not in silos, and we need to bring together in terms of implementing policies in the best way possible to make access to any single citizen. Thank you.
Thanks a lot, Iñaki, and we'll run this this session a little bit like before, so we'll get everyone back on stage in just a bit. And very interesting indeed to hear about this very recent plan, you know, and definitely any examples that we're discussing then at European level, and it includes, you know, very strong links to European initiatives. But we go now to the next bit. We now have Gianni De Enrico from Italy, from Toscana Life Science. But Gianni, you're going to bring the experience with the EP-Per-Med partnership, correct?
Exactly.
The floor is yours, and slides should appear anytime soon.
So, good evening, everyone. And once again, thanks a lot for the invitation. I am Gianni De Enrico. I'm head of project management office at Fondazione Toscana Life Sciences. Today, I'm bringing the example of the European partnership on precision medicine. Particularly the high involvement of European region in these public-public partnerships, but also the expertise and the experience of other projects that have been funded within the Mission Cancer, like Mammoscreen project, of which we are the coordinator, and of course, Impact IMA. So first of all, the project is huge. I tried to bring the information that are useful for the conversation and the discussion. So first of all, the numbers of the partnership. We involve 61 partners, which have invested over 275 millions, on which the European Commission has topped up additional 100 million. So for the next 7 years, this partnership will be investing in research and development something like 375 millions. The very important things are two. The first one is that 85% of this budget is going to third parties, so research communities, innovators, healthcare facilities, and so on and so forth. And the second part is that this is a partnership that already involves 11 European regions. We have highlighted a lot how the regions are represent the quadruple helix, so they are already ecosystems, so it is of utmost importance to involve them in this kind of initiatives. The structure is very easy. We have 5 work packages, and TLS is the lead of the work package 5, which is the one that is responsible for all the types of collaborations. We have heard many times the word synergies, collaborations, and this is within our responsibilities for the next 7 to 10 years. The regional approach didn't happen by chance. This is something that was born something like 10 years ago. We, first of all, we collaborated in an Interreg project on innovation and translation in aging, so technology for innovation and translation in aging. We understood, and BioF was one of our partners, we understood the importance of regions, and we decided to collaborate and to understand which role the regions, the European regions, can bring in personalized medicine. So we submitted, and we got granted the European project Regions for Personalized Medicine, which then came into the European Partnership for Personalized Medicine. These are the overall aims of the European partnership. We have one part dedicated to research funding, we have one part dedicated to innovation, and one part dedicated on implementation in healthcare systems. So we try to let's cover the whole life cycle of research, innovation, and implementation. We are, every year we are publishing research and innovation calls, networking calls, technology calls, and so on and so forth. Just for you to know, there is right now there is a joint transnational call open on personalized medicine for cardiovascular, metabolic, and kidney diseases. The deadline is the 10th of February. So not only that, we also provide continuous training for researchers and innovators. These are two examples of trainings that we have developed. One on research integrity, which was carried out last year in Berlin, and the one that is going to happen next month in February in Paris on data management in personalized medicine. Sorry, I'll speak closer to the microphone. We also have the mission within the Work Package 5 of disseminating personalized medicine among generic public. So we have been building and delivering podcasts. There are two seasons. The first one is on, let's say, on the evolution of medicine up to personalized medicine. And the second one is actually narrating the stories of people that have received personalized medicine treatment and their life have changed and in positive. There's another QR code for you to actually, you have the possibility to listen these on all the platforms. In-situ visits, we try to let's say cross-contaminate all the research centers among Europe. So we bring the most advanced research centers close to the, let's say, less advanced research centers. This is the one that happened last year in the Swedish Precision Medicine Center in Stockholm. And this year we were actually in Brno in the Center for Precision Medicine, which organization was supported by the Czech Health Research Council. Last but not least, we also, among others, we also have created a novel global data set that comprises all the scientific literature, patents, and clinical study publicly available that fall within the scientifically accepted definition of personalized medicine. This is a database of over 90,000 documents, all on personalized medicine that now we are validating the platform, but this will also be made available to policymakers and the researchers to, let's say, advance and update regional and national policies. And with that, I think I can conclude my speech. Thank you so much.
Thanks a lot, Gianni. And I think one of the most interesting thing is as well how in this case, regions also drove the process forward and are leading the process, and that's quite important in the EP per Med as a good example of how things can happen. But we're moving now, EP per Med, and of course, like we've been talking about ecosystem, as part of the ecosystem, of course, we need to, of course, have on board the industrial dimension. We're very happy to have Agnieszka Krukowska, Director of Government Affairs and Policy from Johnson & Johnson Innovative Medicine, that also came from the FPA PO Oncology platform. So Agnieszka, the floor is yours, and slides will be up in a second.
Exactly. Thank you so much for the invitation. And as Michele said, I'm Agnieszka Krukowska. On a daily basis, I work for Johnson & Johnson, but today I represent the industry, FPA, the Trade Association for Innovative Pharmaceutical Industry in Europe. So more precisely, also within FPA, we have a group called FPA Oncology Platform, and I wanted to bring to your attention one of the projects that we do as a group, more specifically on precision medicine. So maybe just still a few words on the FPA Oncology Platform. We are a group of like-minded companies and local trade associations who is willing to closely work with policymakers and other stakeholders to jointly advance the oncology policy agenda at EU level, really trying to make the difference for the patients and healthcare systems for today and tomorrow. So, as I said, I was invited to talk about one project. Actually, maybe I shouldn't call it a project, but rather a journey. Project might imply an end date, while we are on a continuous journey together in order to advance precision oncology agenda in EU. Back in 2023, we got together as a group, and our main objective to start with was to really map the,
precision oncology landscape in EU. What are the initiatives that are currently taking place, both at EU level as well as at regional and national level? What are the key messages? Who are the players? And with that kind of mapping done at the end of the year, we really kicked off in 2024 with content developments. So two things happened in 2024 that were for us a key milestone. One thing was developing fact sheet, advancing precision medicine oncology in the EU. And what is important about this fact sheet is that we jointly identified 3 priorities that as a group we want to focus on. The first priority is awareness about precision oncology among patients, payers, HCPs, etc. The second one was about the workforce and infrastructure, so all about testing capacity, the digital infrastructure, etc. And the third one was about funding and reimbursement. So does the testing and drug go hand in hand in terms of reimbursement? Are innovative payments model being used? So these were the 3 priorities we decided to focus on. And towards the end of that year, we really have a dynamic event at the Committee of the Regions, which brought together really 130 stakeholders in the room and even more online, which was really for us like this momentum for the EU regional dialogue around precision oncology. And we felt that was really the start and momentum, and we didn't want to lose that opportunity. There was an appetite from all the different parties to continue that dialogue together. Therefore, in 2025, we went into more deeper discussions in smaller groups, in workshops, in bilateral conversations on what is really that we can do together as a group to change the landscape, to promote certain practices across the region. And today, we started towards the end of last year, but with that group of experts that you see in the right top corner, we are working on a white paper. And this is still work ongoing. But in terms of the process, I already said we brought a group of diverse stakeholders with different profiles who all came with more than 30 different case studies of different practices in terms of precision oncology across the entire ecosystem. And out of those 30 cases, as a group, we applied clear filters to find out the most applicable ones. It was, we looked at whether the case studies have measurable outcomes, what is the geographical representation, and can they be really replicated in other regions, can they be scaled up. So as a result, what you will soon see in the white paper will be the 9 case studies and 6 promising practices. One may ask what is the difference between a case study and a promising practice. Case study is basically for us more mature with clear measures, identify clear measurable outcomes, while promising practices has a definitely strong potential, but maybe that outcomes is not yet measured or it's work in progress, but something to definitely continue to monitor. So this is just a quick snapshot of the case studies that we've identified for the white paper. On the left side, you see clearly the 3 priority areas that we work on and the different case studies and promising practices that belong to each of the pillars, as well as the countries that they come from. But most important is also, on top of the case studies, there are also other elements that you will find in the paper that are equally important. One thing is the archetypes. So through the work, through the case studies that we've analyzed, we were able to draw some conclusions and identify archetypes and patterns of recurring challenges between the different countries and the regions. So we believe that when a policymaker looks at those archetypes, they can use it almost like a diagnostic tool to see where the gaps are and what practical solutions can be applied to solve some of those challenges. And the second element of that white paper will be implementation toolkit for the member states. So really clear evidence-based recommendations based on those case studies, and they can be applied either individually or as a whole package on how to really upscale the precision oncology care in a particular country or a region.
So to summarize, please stay tuned. We are in the process of finalizing the paper. Our official launch will be on the 5th of March in Spain, together with the local trade association. This event will bring together different stakeholders and to have a joint discussion and deeper discussion specifically for the country on those different priority areas. So, but of course, this is only the beginning. We hope to have more of those national and regional discussions, having our paper really as a starting point. So, but of course, beyond that project, as FPIA Oncology Platform, we really hope and we will continue to support evidence-based policymaking. We will support the uptake of such case studies, and we really hope, for those who don't know us, to really be for you this one unified industry voice, and we hope to play also a role in the whole ecosystem and collaborate with you to advance oncology policy. Thank you.
Thanks a lot, Agnieszka, and indeed you also mentioned the event at the Committee of the Regions in 2024 that we also had the pleasure, also with a colleague from IRST and Emilia-Romagna, to be an integral part of, and indeed it's quite a nice initiative with indeed like a kind of a path towards collaboration. So looking forward to what's going to come next. And in terms of coming next, we haven't talked a lot about data yet, so I think we need to close that gap immediately, and who better to do it than Nienke Schutte. Nienke is the project coordinator from Cienzano of the TEDAS2 joint action, and of course, Nienke, for you it's quite important to also connect the dimension on health data and cancer as well. So the floor is yours, and the slides are also here.
Thank you, Michele. Yes, so thank you for the invitation. I'm always very happy to talk European Health Data Space and the project supporting the implementation. So my name is Nienke Schutte. I am the head of the innovation unit at Cienzano, which is a research institute and the Belgian Public Health Institute. Today I will be talking to you about TEDAS. So we first start here. So this is actually a screenshot of the World Health Summit in 2020, which was online in this case due to the COVID crisis, where Ursula von der Leyen already preluded to the European Health Union that the European Commission wanted to set up. One of the pillars of this European Health Union is not only the Beating Cancer Plan, and also, of course, crisis preparedness was a big topic, but also one of the pillars of the European Health Union is the European Health Data Space. So in 2022, there was published a draft, a proposal of the European Health Data Space. Then it kickstarted some technical working groups in the Council and the Commission, the trilogues, of course. And then in 2024, in April, there was the provisional agreement on a new regulation to regulate the access to and the findability of health data in Europe. Then, I think it was in the end of 2024, in December, there was finally a final adoption of the European Health Data Space regulation. And this year, on March 26, the regulation came into force. This means that it's already there, it's already in force, and it's already something that we should adhere to in the member states. But of course, this is something that is so big because it affects not only people using the data, it also affects people holding the data. It also affects member states because they have to set up specific bodies to adhere to the European Health Data Space. That is why there are several projects set up, some are already finished, some are still ongoing, that are supporting the implementation of the European Health Data Space. Here I have a few listed. Some of them are specifically addressing the primary use of health data, so that means using health data for intervention, diagnosis, to actually make a person better. But some of them are also specifically for the secondary use of health data, so using data for research, for innovation, for mandatory statistics, official statistics, educational purposes, etc. So today I will be focusing on the TEDAS joint actions. There were actually two. The first joint action ended 2 years ago, and it ran until 2023, where we developed joint principles for the secondary use of health data. So this project actually helped build the regulation, because then in 2024, we finally had a signed regulation for the European health data space under the Belgian presidency, and we're still very proud of that. Then in 2022, another project kickstarted, another joint action in which it is aimed to prepare the ground for a harmonized implementation, because we now have a regulation with a lot of rules, guidelines, and a framework, and this project will help not only data holders, but also data users and other agencies and health bodies to implement the European health data space. So let's focus on TEDAS 2, the project that is currently ongoing. We have a couple of work packages, and it actually follows a little bit the user journey. What is a user journey? It's the steps from you have a research question, you need to access data, you need to do the calculations, the analysis, and then you have to publish. And actually this project follows all these different steps in the user journey. Of course, we have a work package dedicated to communication, collaboration models, serving citizens, because of course there also needs to be an information platform where citizens can see how their data is reused. But then on the other side of this graph, you see the work packages that actually deal with this user journey. First, you need to discover your data. So the TEDAS project will help you understand what the European health data space requires you to do in order to make data more and better discoverable and findable. Then, of course, you need to access this data. So the TEDAS project will provide you with technical specifications and guidelines on how to organize giving access to the data, not only for data holders, but also for data users and other bodies that need to be set up in the European health data space. And then, of course, you also need to do safe and secure processing in a secure processing environment. And this work package will provide technical specifications for these secure processing environments. So this is what the TEDAS project will deliver. So what are the expected results? The TEDAS project will be producing guidelines and technical specifications, so that helps you implement the European health data space. Focus for data users, data holders, and health data access bodies. What is then the impact? Of course, better preparedness for implementing the EHDS, but also better coordination on policies, less fragmentation, because we expect national or member states also to have additional legislation built on top of the EHDS, and the TEDAS project aims then to harmonize this implementation. Of course, this is not a thing that is just being created and then going into force. All of the guidelines that we produced have undergo or will be undergoing public consultation. This means that everybody can provide input on the guidelines to help them make better. So you can see, first we draft, then we have the public consultation, and then the final guideline. This not only serves to be a comprehensive guide for when you want to implement the European health data space, but it also serves the European Commission in drafting, implementing, and delegated acts that will clarify the implementation of the European health data space regulation. The last round of public consultations will be set in May and in June, and the topics that we will address there are collaboration with third countries, data enrichment, informing citizens, etc. So keep an eye on the website. Here, I just want to give you an idea of what is in these guidelines. This is the one that we worked on very extensively. It's how you describe your data, because if you are a data holder, if you have health data, you need to describe it, provide metadata. So what's in a guideline like this? There's clarification. What is EHDS data? Is my data EHDS data, or is it not? It also will provide you with why you need to describe your data. What is legally asked of you to do if you are a data holder? Then an introduction to the standard that you need to be using to describe your data. There's one metadata standard for the whole European health data space. And of course, it will provide you with practical instructions, tips, examples to help you implement this standard for the European health data space. So this gives you an idea of the details of the guidelines that are produced in the TEDAS project and help you implement the European health data space. Feel free to email me if you have any questions, and thank you so much for your attention.
Thanks. Thanks a lot, Ninke. And I also have to say, indeed, back again for the point of view of involving regions in this process, because as you know, with the implementation of the HTS, in many cases will fall at that level. It's been a pleasure so far, you know, to inform, of course, our membership about the project and try to facilitate the consultation. So also important reminder indeed about this last round and in general to have a look at all these guidelines, because you know it's going to be a complex thing. So to decomplexify, I think the work that Teda is doing is quite important. But and again, I think a fil rouge that we had throughout the day is, of course, the role of regions is in advancing and in getting engaged in cancer research, in cancer policy, and in cancer care delivery. So for the next speaker, actually, I would like to call to the stage Kyle Galea, Project and Policy Manager for ICT and Health Clusters at ERWIN, a friend organization of Euriga for sure, that we've been working a lot with cancer. So Kyle, I think you're going to bring a little bit of the regional again perspective.
Hello. Okay, and thank you very much for that. So with that excellent introduction, I don't think I'll be needing to reintroduce myself either. I'm also running a very small cold, so if that comes out more tortured, I apologize for that. So as previously said, I'm Kyle Galea, the Project and Policy Manager for ERIN, focusing specifically on digital and health. And I'll be discussing more about the roles of regions and the networks that support regions in the broader impact of, let's say, the maturation of medical research. So this is the thing. Under.
There, at the corner with the clock is.
I see. Could you help me out a bit? Perfect. So, Europe has a very strong home field advantage in a large amount of the research fields we normally associate with medical research, the immunological, oncological, genetic, etc., etc. This being said, the structural nature of the European research area does limit certain aspects tied to the maturation of research when it comes to the taking of very high impactful, very deep, in-depth, and very excellent research being conducted by research institutes and by scientists, and the attempts to really mature that research, to really advance it up the TRL level, to move it more into technological products, into services, and even to startups and scale-ups is limited by certain fundamental issues tied with the European market and the European landscape for, of course, research and technology. We can see this in, of course, the decline of clinical trials happening within the European Union, especially compared to the rising presence of international competitors and growing markets in the more broad global framework for research and innovation. My apologies. This is why we need to take a very specific perspective towards the regional perspective, whereas one might say that there's an assumed assumption that excellence is something which is concentrated in a given nation or in a given ecosystem. The European research area, even in its medical manifestation, is very much an ecosystem of ecosystems, and that the medical field in particular is extremely territorial. It is extremely place-based. It is extremely focused on the treatment, on clinical trials, on access to populations, on access to data and case studies. And therefore, the regional perspective, the regional dimension is one which needs to be approached with a specific amount of attention. This is given enhanced importance to the specific fact that in a number of nations, of member states, the regions themselves have a specific role when it comes to the management, when it comes to the authorization, towards the financial governance, and towards the operational upkeep and infrastructural upkeep of medicinal services, medical services, provisions, preventions, and immunization policies. Therefore, research and innovation as a whole plays a very core development, both from the perspective of the regions, and the regions have a very core and very critical role to play in the resilience of these regions, the defense of their populations, the ensuring that these populations not only can give, they can actually receive services and medicines and medical support that is needed for a healthy population, but also that these regions can be themselves test beds for services, for products, for startups and scale-ups, to be able to contribute to a broader lattice work of European competitiveness, resilience, and the acquisitions of our social goals. This is where organizations such as ERIN come into play. ERIN, the European Regional Eastern Innovation Network, has been in operation for over 20 years and has now gained over 120 regional stakeholder organizations, from the westernmost parts of Ukraine to the westernmost parts of Portugal, from the far north to the far south. And through this very long-standing approach in the broader European policy framework as a whole, we have developed a very strong bond with our stakeholder organizations, and we have created a very long-running relationship of co-creation from both the policy and the project foundation with these organizations. One of the main cornerstones of ERIN's approach is the idea of place-based innovation, is that innovation is not something that is like space blind, it is not something that is purely statistical, but it is something which is dependent on contextual factors which are very much present within the localized, dimensionalized, even territorialized regional happenings in a given area. The academic presence in a given region, the material substances, the access to raw materials, the population densities, all of these provide a broader context which need to be taken into consideration to allow for a purely and genuinely robust innovation ecosystem. And then the scaling and interlinking of these ecosystems to create a de-siloed and interoperable framework of ecosystems. In terms of ERIN services, these are mainly built in two fundamental pillars, those being policy and projects. Projects being that we, both as an individual agency entity, we are associated and actually participate quite strongly in a number of projects. And from a policy perspective, we do provide, or we constitute a certain feedback function where we consolidate the voice of the regions in support of other regional organizations and kind of contribute that to high-level institutional inputs or requests for feedback. Now, in terms of how we are structured, I won't go into this into depth, don't worry. But for those eagle-eyed amongst you, you might realize that this seems a bit similar, that we structure our working groups to mirror Pillar 2 of Horizon Europe. And that is a very intentional governance structure. It is mainly done so specifically towards the goal of ensuring that all of the feedback and all of the work on a technical level and on a, let's say, technological domain level move in parallel and step by step with the developments in European policy. This is also something which changes on a year-by-year basis to reflect any evolutions or any changes in priorities that happen at the European level. Of course, I'm speaking on behalf of the health and ICT working groups over there. In terms of, to give you a bit of a cross-section of how the health cluster works specifically, there is one member of the ERIN Secretariat acting as a secretariat, that being myself, and then we are co-chaired, more or less, by a panel of regional representatives, which in my case would be Ile-de-France, Navarra, Copenhagen, Wasseyottaland, Catalonia, and Utrecht. This is then followed by a yearly agenda, which of course changes on a year-by-year basis, wherein the key policy actions and foci identified by our regional stakeholders are themselves highlighted on a yearly basis and used to create events, workshops, stakeholder engagement exercises, webinars to tackle these specific areas. To pick up some sampling from last year's, those would be aspects such as the mission on cancer, digital transformation, the European health data spaces, the EU life science strategy, and more broad focuses on stuff like EU funding in a more broad fashion, skills in healthcare, etc., etc. Now, with that covered, some key examples of some of our more project-based work or more of our supporting functions would be, let's say, the elevation of some excellent projects which have been really serving as North Stars to do with the place-based approach of health research. The first one which comes to mind is the RIVs, the Regional Innovation Valleys, of which apologies. The two main ones which kind of like set the pack are obviously PRECISE-EU, which focus on personalized medicine and coordinated by BioCat, based in Catalonia, and UNITE, which is chaired and coordinated by 28 Digital and focuses specifically on tackling digital health. These are excellent examples of how an ecosystemic model allows for a very, very conducive and very excellent way of tackling regional issues in health R&I, and to really kind of allow for a sustainable testbed of products and services. The second is ECHOS, which is the European Cancer Mission Hub project. And this is one of the main manifestations, or a very clear manifestation, of the broader EU mission on cancer, of which ERIN, very gladly working with Euraga, are cooperating to provide more of a regional dimension to the more national perspective provided by the ECHOS from the get-go. The third is the Territories in Action Preparatory Action. Now, this being a preparatory action put forward by the Parliament, but also led by the JRC of the Commission, focuses on creating an policy experimental testbed to allow regions or territories to really trial or experiment with policies in any given area. Following the creation of a number of specific technical work streams, ERIN is heavily engaged with a number of them, but specifically on digital citizen services and healthcare, we have been heavily engaged in contributing the perspective of the regions and in allowing them to trial experimental policy projects and, to a degree, even reforms in their own contexts. The three main giveaways that we have with regards to the reflection so far, now this is still a very evolving process, the journeys are not complete yet, is that while goals and priorities are normally extremely contextual, the issues faced by these territories, which vary from a very low degree of maturity to a very high degree and a very kind of like robust and proactive approach towards innovation, they do suffer from common issues, such as inability to get funding, or an ability to create or articulate a funding strategy in their broader project approach, or a fundamental disjunction with regards to governance structures. These are recurring issues which tend to arise in even very superficially different seeming projects. And therefore, that was something very enlightening that kept reoccurring throughout the journey as a whole. But the second is that the needs are normally very cross-cutting. So just a reflection of the first point. We also have a project development tool, which is an organic kind of API scraping tool that kind of we then curate internally to provide the main calls that would be of interest towards regional stakeholders. This has been a very, very useful tool. We have received a very strong amount of interest and a very positive, let's say, positive feedback overall from the regional stakeholders that we are in contact with. And they have found it very useful in kind of like cutting out the middleman and speaking to different stakeholders in the regions towards aligning and kind of creating, either highlighting themselves as coordinators or highlighting their interest in a given area. It's also something which we procedurally push out and kind of like has been getting a significant amount of traction overall. Finally, and focusing mainly on the policy perspective, is that we, of course, monitor EU-level policy recommendations and policy legislative changes quite closely, and we constantly provide the regional perspective, both kind of from our in-house kind of understanding and through a strong degree of communication and consultation with our regional stakeholders, with examples including our input to the AI Continent Action Plan put forward by the Committee of the Regions towards the Commission as a whole. That's it more or less, feel free to reach out, and it's been a pleasure.
Thanks. Thanks a lot, Kyle, for the overview, and indeed a lot of occasions where regions play a central role. And we kind of going back when we started also with Antonio Paenti from the Commission, and we're finishing again with the European Commission. And I'm happy to welcome on stage Kay Dagan-Walls from the EU Cancer Mission Unit in DGRTD as a policy officer. Kay, the floor is yours. We're running a little bit late, but we'll indeed give all the time that Kay needs, and then we'll try to have some quick Q&A later. So if you have questions, start preparing them.
Thank you very much for inviting me to talk about the Cancer Mission. And as Michaela said, I'm a policy officer in the Cancer Mission Secretariat in DG Research. So I'm going to talk to you about how the Cancer Mission is helping to ensure better alignment between research policy and funding to deliver impact. So as you're aware, the Cancer Mission has many challenges, and the burden of cancer there you can see on the left-hand side, the statistics. So a mission approach is used to address it, and a mission is a portfolio of actions across disciplines intended to achieve a bold, inspirational and measurable goal within a set time frame, so it's up to 2030, with impact for society and policy making, which is important. So the goal of the Cancer Mission is to improve the lives of more than 3 million people by 2030 through prevention, cure, and for those affected by cancer, including their families, to live longer and better. And we're working jointly with Europe's Beating Cancer Plan to do this. Now, the mission is delivering real-world results, and innovations from many of the projects are transforming diagnosis and treatment decisions, and is directly benefiting patients. So the mission has 4 objectives: understanding cancer, prevention and early detection, diagnosis and treatment, and the quality of life. And then we've also other transversal priorities, such as personalised medicine, paediatric cancer innovation, citizen engagement and equity. So we have a number of concrete actions engaging at national, EU and international levels. We have lots of research and innovation investments through Horizon Europe and beyond. And we have a network of comprehensive cancer infrastructures we're setting up. And then, of course, we have the digital platforms, UNCAN and the European Cancer Patient Digital Centre, which we're developing as well. And then we have synergies with EU and national initiatives, and we have a big programme on citizen engagement and activities at EU level. So the governance model that we have, we work very closely with the Europe's Beating Cancer Plan, which is the EU policy initiative, and then we have the research and innovation actions on the Cancer Mission side. So we're bringing together health and research ministries under the subgroup on cancer, and this is to foster an integrated and continued dialogue around cancer. So it ensures that scientific discoveries are directly informing political decisions and innovation translate into better healthcare delivery. So it's a comprehensive approach between ourselves and the Europe's Beating Cancer Plan. And then another important initiative is the network of national cancer mission hubs, which was mentioned just earlier. And this is to facilitate the integration of EU actions at national, regional and local levels, and that includes the regions, through stakeholder engagement and cross-policy dialogues. And a number of cross-policy dialogues have taken place, and I've attended a number of them where it brings the players in each country in the cancer area to work together. And 5 national cancer mission hubs have been launched so far, and there are 6 more in preparation. So these are laying the groundwork for a European network of national cancer mission hubs. So they're quite important to integrate the cancer mission into each country at all levels. So this is similar to what I just mentioned before, building synergy between research and health to address cancer. So the Cancer Mission has invested in the years 21 to 24, since it started, 488 million through Horizon Europe for 62 projects. Then the Europe's Beating Cancer Plan has invested 475 in the same period through the EU for Health programme, and they have 10 flagships initiatives and 32 supporting actions. So it's a complementary portfolio of research and cancer care projects that we have between the two initiatives. So the synergised research and health policy actions and investment at EU level. So just to give you some results from the Cancer Mission so far, as I said, we've invested 488 million into 62 innovative R&I projects between 21 and 24. We're supporting cancer research across Horizon Europe, and there's about 2 billion euros funded with synergies with other initiatives such as the Innovative Health Initiative, European Innovation Council and other EU missions. And then we're creating the digital UNCAN platform, and we're increasing research activities of comprehensive cancer infrastructures. And this synergizes with the Europe's Beating Cancer Plan comprehensive cancer centres. So we have 12 R&I projects on the understanding of cancer. There are 18 projects to test innovative approaches to prevention and screening. And then there are 17 international pragmatic clinical trials for diagnosis and therapies. And as you know, that the pragmatic clinical trials are evidence directly available to clinical practice. And so they're close to the real world, as we saw that earlier. And clinical trials are the bridge between discovery and delivery. And just to give you some more information about the Cancer Mission, I mean, we have, we're working with the Europe's Beating Cancer Plan. We're promoting citizen engagement activities. And again, we're talking about the network of national cancer mission hubs. We're also building synergies with other initiatives, topics with the Innovative Health Initiative. We had a topic in the 2025 work programme with the Cities mission. And then, of course, we have projects with the EU for Health with parallel topics on young cancer survivors in 2024. And then we have funded an initiative to support funding pragmatic clinical trials with cancer charities across Europe so that they'll pool their funding to work together. And then we have national and regional cancer funders who are supporting the coordination of translational research. And because of the Cancer Mission, number of member states have availed of other funding using the Resilience and Recovery Fund to implement cancer priorities. And you can see there that different countries have, the Czech Republic is building an oncology institute, Croatia is purchasing equipment for prevention diagnosis, and Greece has established a new radiotherapy centre. So it's to build on the momentum from the Cancer Mission and using EU funding to do that. And this slide is just a representation of all of the projects that have been set out from 2021 to 2025. And you can see the ones that are shaded are the ones for the 2025 work programme, which is being evaluated at present, and the results will be available soon. So you can see the results of all of these topics, all of the projects that have been funded are all included on the Cancer Mission website, and you can see all the details of all the projects and their websites as well. So to finish, I think that in the next framework programme, that there's potential for scale-up of synergies created by the missions. That, of course, there's the life science strategy, and in that there's Clinical Trials Investment Fund, which is part of that. So there's another opportunity to continue this work. Thank you very much for your attention.
Thanks a lot, Karen. You can actually stay here on stage because we're going to call all speakers back on stage, please. So, Iñaki, Gianni, you can just sit here if you want. Agnieszka, perfect. Of course, we don't have Tit, but still quite a rich panel. I think those are still here. We have enough because Tit is not here. So we're running very late actually. But what I would like to do in the interest of involving the audience is actually to start to see if there are some questions from the attendance here. So just looking a little bit around. Yeah, we have one question. So if you can introduce yourself and address the question to everyone or to someone in particular, please.
Okay, well, thank you for your presentations. It was very interesting to hear all the efforts and initiatives that I hear. My name is Isha, and I'm representing an EU-funded project called Guide MRD, which is aiming to address earlier detection of cancer relapse and avoid overtreatment by improving the utility and clinical implementation of ctDNA-based MRD testing. So I wanted to share that as part of our efforts, we've been doing a lot of system mapping work to understand what are the current gaps and needs in the system, who are the key players, who are the influencers. And one of the things we've certainly realized, which you've also highlighted, is that there is a lot of fragmented evidence, and there is a need to harmonize the data and information to actually inform policy and funding decisions. So my question to you would be here, what do you feel, could be any of the panelists who resonate most perhaps, what do you see as the most important systemic change that is needed to harmonize evidence across initiatives to ensure that policy is truly evidence-based across Europe?
Very well, you anticipated one of the questions that I had for the panelists, so perfectly done. Anyone wants to take it? So how we move from translation evidence, but maybe Iñaki?
First of all, thank you very much for the question. I think it is very accurate and to the point. I think one of the main aspects that we should take into account it is that when we have common goals, things happen. And I think one of the challenges it is not the fragmented pieces of information that we have all over Europe, but that happens also in the world. But is if we have common objectives in terms of covering those needs and gaps, and when it is that, something is happening. And in this sense, I think that something that has occurred with common approaches to the use, for example, of observational data in terms of being used for policy making, like the initiatives on Eden Odyssey that happened, for example, and I started with the pandemic of COVID-19. It is a clear example of how to proceed. So when there are people with data that are fragmented, but they wanted to have good data in terms of making decisions, if they work together, that is the case. Another thing it is, for example, also using observational data on the aspects related to safety and efficacy, and it is the Darwin initiative from EMA. So I think those are the things. So instead of perhaps focusing on interoperability of data and many other things, it is focusing on cases that are important for different organizations, and in reality they are going to be implemented into clear policies.
Oh, well, Ninka, you want to come in as well on that?
Yes, thank you for this. I also wanted to focus a bit on the data, because if you say systemic changes, we have now the European Health Data Space that provides a legal framework for the verification of data, but it might not be enough, because you can not only if you have data that's interoperable, there's also analytical pipelines, there's common data models, there's data models that should be interoperable as well. And these initiatives already exist out there, but now they need to connect to and build upon the framework that the European Commission is laying out in the European Health Data Space. So it's a starting point, it's an enabler, but we're not there just yet. And now what we also see, I think cancer is the perfect example. There have been a lot of EU projects on cancer, but the connection with, for example, European Health Data Space was missing. And luckily now, in most of the projects that were presented that will be kicking off or are be kicking off, were kicked off last year, finally you see them come together because they're not in an existing space. It's just one data space now for health, but also for skills. There will be one for the Green Deal, etc. So I think we can work from here.
Anyone else wants to come in? Maybe Gianni, Kay? Maybe you want to come as Gianni and Kay, yes.
Okay.
Then you could go. Okay. Yeah.
No, I
of
just
course.
wanted to
we'll
add
do the full round.
from the different perspective, I think, and what my fellow panelists also said, I think is really integration of these different profiles, different group of stakeholders to have the structured dialogue. So the more people with diverse background that look at the certain data will be able to provide different experiences because we work towards the same goal, but we have different, experience, different role in the ecosystem, different means to implement this in practice. So that's one thing. And second thing is, I think before we turn the evidence into implementation and impact assessment is also a critical point. So out of all this data, and if you hesitate, which one is the right one, I think another important element is to see what will make the biggest impact and which one will make the impact.
Great. Gianni, you.
So I think another point that is worth mentioning is harmonization of clinical trial regulations. If we have, if we shed light on clinical implementation and healthcare implementation, we come from an experience where sometimes you have to run international, multinational clinical trials. The way the clinical trial regulation is implemented at national, regional level is also a kind of barrier to the implementation of these clinical trials. We are, as I said, we have an experience. We have managed to enroll in one study which has been funded by the European Commission under the Mission Cancer, something like 7,500 subjects. But the bottlenecks we have encountered are substantial, and I think if we also work in this direction, the research outcomes will come to the patients much easier and much quicker.
Yeah, just I suppose from the point of view of the Cancer Mission, we're looking at all of the projects that have been funded and looking to see where we can scale things up, and then looking at the gaps in the projects that we funded or in the areas that we funded. But also, it was alluded to earlier on about the clusters, and that's one way that we're looking at the projects working together from one particular call, and that part of it would be looking at the research aspect as well as other aspects, but that way, that they can work together and that they're not overlapping on what they do.
Perhaps a very quick point. I won't elaborate more on data, as my colleagues have done quite excellently themselves, but rather more on the ideas of case studies. Because, for example, for our regional membership, what they have found very useful is more the sharing of best practices when it came to, let's say, common clinical or common medical problems or challenges they were having in their own kind of environments. Basically, it was a very simple, we are having this issue in these kind of like specific kind of contextual and territorial limitations. Has anyone in the rest of the membership faced any similar challenges, and how did you tackle them? And the access of, like, let's say, case examples or case studies or projects which succeeded or did not succeed for a set amount of given reasons has proven very useful for, let's say, really reinforcing their own kind of like internal reasoning within their own kind of administration.
Good. And as we're running out of time, but I would still like to get one very last comment from each one of you. We've been hearing a lot about keywords like impact assessment, of course, awareness raising, involvement of stakeholders, of course, a lot from the regional point of view. But and the topic at stake is how we can, transform research as well into impact to people. We're going ahead to a future of health policy, a future of health funding. In 30 seconds, or even one word, maybe, what's the one thing that you would like to see to change? What's the most important thing that we need to keep in mind to kind of close down that research to impact translation? 1 second to think about it. Who wants to start? Maybe Kay, you want to go?
Yeah, I suppose the National Cancer Mission Hubs are very important for us because that's where the cancer mission will be translated into each country nationally and regionally and locally. So that's very important. And that the ECHOS project, which started that, has finished, but there is another round of funding and that's being evaluated at the moment. So there's great momentum with the National Cancer Mission Hubs. So that will really consolidate the cancer mission and bring it to the local areas, and that perhaps the regions can see what kind of things they want and come back to us, and then we at the cancer subgroup we can then bring that to the health ministries and the research ministries.
Very good. Jenny?
I will insist on the topic of investing more in clinical studies. We know that, as we have heard, in Italy, Spain, Germany, healthcares are administered at a regional level. When healthcare facilities, when hospitals join clinical trials, they give a treatment option to people, to patients, and they also get savings. So the participation, investment in clinical trials also works in the direction of keeping our healthcare systems financially sustainable. So I think we should go in that direction. We should invest more in standardized HTA models, investing more in clinical trials, investing more in reorganization of healthcare governance.
Very good.
So in my view, I think we need three things to make this vision a reality. One is to continue to have the shared objectives. The second one is to make sort of practical tools available. So it's not only evidence that sits on the shelf, but we really come up with practical solutions on how to change things based on the evidence available. And the third one, of course, is a political will, which I think it's a background to make things in the change in the policy space.
Yeah, I think help data holders to make their data findable, metadata, because you can only use buzzwords like AI if you have the amount of data available that is needed to train your models, good quality data, metadata.
So, very convenient. On mine, I kind of would focus on two main things. One of them is maturation, is that we are doing excellent research, and we have been for ages. The issue is always maturity and scaling. So ensuring that, again, I use the technology readiness scale, the technology readiness levels as a guide of, okay, research, but how does it kind of mature into technological outputs, services, and, concrete outputs that can actually help, let's say, citizens. And the second thing, which is very much related to your point, is the idea of interoperability, is that we have a European landscape for health services, but ultimately, because of that landscape being fractured along a number of member states, etc., it is normally, unfortunately, self-siloing. So the creating of an interoperable framework of ensuring that kind of like best practices or data can kind of transfer from one region to another is a very core goal or a kind of aspirational goal in ensuring that there could be a health union for all at the end of the day.
One of the things that I was also stressing in my talk was first of all changing the perverse KPIs. So and how we look at the performance of healthcare systems. We are looking pretty much to structure and processes. So it is length of stays, the length of approaching to the first consultation, and many other things and also the lack of professionals. And I think we need to concentrate much more on incentives that are related to outcomes. That is the first thing. The second thing it is thinking much more on who provides the services in Europe. And the services in Europe mainly, as it has been said also by Erwin and some others, it is provided at the regional level, or at least it is reduced not in the member states, but in the providers of services. And I would say that it is true that we need data, but I don't think the problem is right now data, because technology is there. I think it is much more what we wanted to collect in terms of making good decisions. And this is something that, because we are also creating some kind of burnout and burden to professionals in collecting data, but they are not saying they are not seeing that the systems we are doing things with the data that they are collecting, and also they are not seeing in terms of how they change or how the collection of data changes their lives in terms of improving their professional lives and also improving the quality of the services that they are providing to citizens. So probably it is much more concentrating on which data are needed. I love the quote from Adrian Newey, that was the guy that is running nowadays Aston Martin in Formula One, and he said one of the problems that we have in Aston Martin is we have collecting a lot of data, but they are useless, and I think it is crucial. So it is concentrating on which are the things that are matter, and also they are important for citizens. I'm not seeing the patients here, and not either the citizens, and I think we need to bring both.
Very good. So a big round of applause for the second panel. I think a lot of important things that needs to be done. I think it's doing what matters, but also where it matters. And I think, we are here in the House of Regional Authority, so that's indeed very common in many countries as a key point. So before we close, I'm going to close very soon. I'll just leave to give the floor 1 second. Close, indeed. I'm done, I'm close. There was more than enough from my side. I think people have been hearing me for a while, but I think it's just important to reiterate that it's great to have this type of discussions where we bring together stakeholders, projects, because we show that things are happening. So we just need to keep forward and learn from what we've been doing.
Definitely, I want just thank you all to being here. Thank the speakers. I want to give a big thank to Michele Calabrò. We had really a great moderator. A big applause to him. And I think that we are happy that as IRST we really launched this initiative. We started this discussion. We learned a lot. We had some keywords in connecting all the different initiatives, multi-stakeholder participation, also private, public, that's what we are also trying to enforce. We need really to assess the impact of this initiative, and we want to have a faster and better translation of the results of research for our patients. So these are the keywords. Of course, data is very important. We are working a lot on data, and I would be very happy to collaborate also with all the stakeholders that are here today, as well as also clinical trials. Also, we are promoting clinical trials. We have our own CRO, and we are running a lot of clinical trials in Italy. But I think that all these things must be put together. I think it was very important we had today the possibility to discuss together, and I look forward in continuing this discussion in the next few weeks, months, support also maybe West to take decision on where to put money and which are the programs that need to be funded, because I think it was important also for the EU Commission to listen about what are the needs, what are the ideas that come from you, from the experts. And so I think that this was a very, very important discussion we had today. Thank you again to all of you.
And maybe we can now head to the networking, I would say, and we can also leave in the background the QR code for the endorsement of the manifesto, so you'll be able, to have a scan of it and maybe discuss it during the cocktail. So thank you again, everyone.